Good morning, everyone, and welcome. I'm Debbie Plotnick. I'm Vice President for State and Federal Advocacy at Mental Health America, and we're so delighted that you could join us today. This portion of our program is certainly one of our favorites. It is saying thank you to legislators who have been mental health champions from all over the world. But first, I want to thank our sponsors, Allergan and Alkermes and Janssen and Myriad, Erickrin, Otska, Takeda, Lundbeck, Alliance, and Teva. Without our sponsors, we couldn't be here today. And we also wouldn't be here today without our friends at the National Legislator Organizations. We're so pleased that we're able to say thank you to our members. And with that said, we have a welcome from Carmen Hansen from the National Council of State Legislators. Carmen?
Hi, I'm Carmen Hansen, Program Director of Behavioral Health and Pharmaceuticals at the National Conference of State Legislatures. Thank you for inviting NCSL to join Mental Health America in recognizing state legislators working on mental health policy. As a bipartisan organization, NCSL appreciates the work done by legislators across the country on issues important to their constituents. If nothing else, the coronavirus pandemic shows us how no one is immune to dramatic life changes and its effect on our mental health. While we aren't able to be with you in person this year, we hope to see you next summer in Chicago for NCSL's Legislative Summit. Congratulations on your awards.
Thank you, Carmen. We're so pleased to have welcoming remarks. We're also very pleased to have some remarks from one of our previous award winners, Steve Ellison from Utah. And Steve will tell us about what it's meant to him to receive the award and tell us about some of the amazing work that he's doing in Utah that will tie into the policy meeting that we're so glad you're joining us for. Steve?
Good morning. I'm Representative Steve Ellison from the House of Representatives in Utah. I'd like to congratulate you on being recognized as a mental health champion by Mental Health America, which of course is one of the premier organizations in the country working on the issues of improving mental health. Thank you, Debbie, for that kind introduction. A number of years ago, I was recognized as a mental health champion by MHA, which I was deeply grateful for. I actually have my award that I keep here in my office, which means a lot to me, and I hope that it'll mean a lot to you and is very reflective of the work that you've already done and the work that you will continue to do as a mental health champion. As we all know, mental health is a serious issue facing our country. At any given time, approximately 20% of Americans are struggling with some sort of mental illness. The cost to state governments, to the federal government, and more importantly, the deep impact that these challenges have on people's lives is really incalculable. So again, I commend you for the work you're doing and encourage you to keep up the fantastic work and being the champions that you are and that you're being so rightfully recognized today. I'd like to talk a little bit about some of the things that we've been doing in Utah and continue to pursue with the hope that you all can learn from some of the things we're doing. And I always attend every Mental Health America meeting that I can to learn what other states are doing. And I think there's a lot of cross-fertilization of ideas that we can learn from each other. I hope you can see this. We call it the mental health continuum. We've used this kind of as our guide in Utah. I will just go through this really briefly. We have community and prevention programs, including school-based programs at the very top of this funnel. Then we have primary and specialty mental health care. There's a lot of things that can be done in this area in terms of increasing access, integrated care, collaborative care, opening up Medicaid codes in the collaborative care area that is approved by CMS and most Medicaid insurers. Some easy things to do to improve the primary and specialty access to mental health care. The bottom part of this funnel deals with, we call this the crisis funnel. And the first rung right here has to do with crisis contact centers, referral centers, and the National Suicide Prevention Lifeline. As you've probably heard or will hear about 988 efforts that began here in Utah, that will go into effect in 2 years approximately, where anybody in America can dial 988 and be connected with the National Crisis Lifeline. Something I'd encourage you to do is find out how robust the crisis call centers are in your state. We've run a number of bills here to improve a crisis line response. When we first looked into it, we found we had 20 different crisis lines just here in Utah. So we passed legislation saying there was minimum levels of training, there had to be rollover, and no call for help should ever go unanswered. So trying to get 988 on par with the service that you expect from 911 is a key component of achieving parity for mental and physical health. What we found in Utah is that as we've promoted our crisis number, 1-800-273-TALK, the National Lifeline, we call it here locally the Utah Crisis Line, just to make it feel like it's more of a local resource, even though it goes through the National Lifeline network. Those calls go to our crisis center. For about 90% of the callers can be stabilized online, on the phone. About 10% will need the next rung right here, which is a mobile crisis outreach team, a mental health ambulance, so without the flashing lights and the uniforms, cutting edge treatment in mental health, the push to re-examine some of the services that law enforcement officers. This is one of the key ways that law enforcement can be more focused on what they're really good at, and mental health workers can focus on what they're good at. Typically, they can stabilize about 90% of the people with a mobile crisis outreach team, which is no cost to the patient. And then some need to go into a crisis receiving center. This is a 23-hour facility. We're in the process of building 4 of these across the state of Utah that will cover about 80 to 85% of our population. About 65% of those individuals in those facilities can be stabilized in 23 hours. And then that brings us to the next rung right here, where they would go into a subacute 3 to 5 day inpatient facility. And then about 85% can be stabilized there. And then at the very bottom, that would be inpatient acute hospitalization. The beauty of this model is we have legislation in every area where the system can be improved. And if you look at it from just a cost perspective, the sooner you intervene, the less cost it is to the state and to the patient, the shorter the duration impact on that patient's life, and the better, the earlier intervention, the better. So those are just a highlight of some of the things that we're doing here in Utah. I'd love to learn more about what you're doing in your states and some of the reasons why you've been recognized as a mental health champion. I believe that the impact that this legislation has on our society is one of the most bipartisan, most impactful from a human suffering perspective, that we can reduce that suffering, improve outcomes. And the best part too is that it, in the end, saves taxpayers a lot of money. So keep up the great work. Again, congratulations. Again, thank you, Debbie, and keep up the fantastic work. Have a great day.
Thank you, Steve. You can all see why Steve is one of our favorite legislators in the country. And speaking of some of our favorite legislators, you're about to see why our affiliates across the nation have nominated, and we have sent awards to some of the country's best mental health champions. We are so delighted to welcome this group of legislators to the ranks of mental health champions as recognized by Mental Health America. So please join me as we sit back and we hear why they've been champions for mental health.
My name is Erin Callanan, and I'm the Associate Director at Mental Health America of Arizona in Phoenix. I'm thrilled to have the opportunity to introduce a true mental health champion and ally, Senator Kate Brophy-McGee. She's a committed leader for mental health policy, and I have the opportunity to see her in action when she sponsored and passed Jake's Law here in Arizona. Senator Brophy-McGee believes in equity, in peer voice, in recovery. She took the time to listen to those of us living with mental health conditions, to meet with Jake's parents, to hear from survivors of suicide loss. She put in effort and dedication and passion, and Mental Health America of Arizona is proud to celebrate her. Congratulations for this well-deserved recognition. Senator Brophy-McGee, we greatly appreciate you. Thank you.
Thank you, Mental Health America, for the honor of this prestigious award from your fine organization. It means the world to me to be recognized. I know we have a lot of work to do, but it's important to take a pause along the way and celebrate success. Thank you. Over my last 10 years in the Arizona legislature, I've met many interest groups, none more compelling than the mental health interest groups. They come for many reasons. They come to tell their story, they come to seek help, they come to be heard, and they come seeking legislative solutions and funding so that we can adequately address the mental health issues in our state. And it's been a pleasure and a joy to work with them. We've made enormous progress. This past session, I was honored to sponsor Jake's Law, which was brought to me by the parents of a young man who committed suicide. Ben and Denise Denslow worked to bring the federal parity law to the state of Arizona, and we got it done in Jake's Law. In a time where politics are really hyper-partisan, Jake's Law went through with massive changes for behavioral health, mental health in our schools, funding on a unanimous vote in both chambers. So a shout out to Ben and Denise Denslow and all the other advocates who made Jake's Law a possibility. Once again, I'd like to thank your outstanding organization for the honor of this award. I'm working hard to make it back to the Capitol because I know we have a lot more to do. I appreciate your taking a little bit of time to celebrate some milestones. I look forward to celebrating many more as we go forward. Thank you.
I'm Mo Keller, Director of Advocacy for Mental Health Colorado, and I'm here today to introduce to you three of our mental health champions in the Colorado State Legislature. We're proud to recommend and recognize Representative Tom Sullivan, Representative Lisa Cutter, and Representative Lois Landgraf. Representative Tom Sullivan was elected just 2 years ago, but he already has made a mark in the mental health public policy arena. Last year, Representative Sullivan introduced Mental Health Colorado's mental health parity bill that expands and enhances mental health compliance in the state of Colorado. That bill passed and became law and is now considered model legislation for other states to follow throughout the country. Representative Sullivan has a 100% score with us at Mental Health Colorado's legislative scorecard for the 2019 session and for the 2020 session. We are proud and honored to recognize Representative Tom Sullivan for his work in mental health at Mental Health America's Regional Policy Council meeting today. Representative Lisa Cutter was elected 2 years ago to the Colorado House of Representatives. She has been a steady and stalwart and a reliable partner on mental health policy in the state for these past 2 years. She also has a 100% voting record with Mental Health Colorado on both the 2019 and the 2020 legislative session. Last year, in 2019, she co-sponsored with Representative Sullivan Mental Health Colorado's Parity Compliance Bill, which has become law and is model legislation for the state, for the rest of the country. She this year was successful in passing legislation that allows for students in the public schools to be able to have a legitimate excused absence for a mental health day. We're proud and happy to recognize Representative Lisa Cutter at the Mental Health America's Regional Policy Conference today. Representative Lois Landgraf is ending her 8-year legislative run in the Colorado House of Representatives due to term limits that we have here in the state, and that's a loss to all of us. She has been a champion in all 8 years on mental health issues. She has a special passion for veterans' mental health and has introduced multiple bills on veterans' courts and the treatment of veterans through court proceedings. She has also introduced legislation dealing with and improving services for individuals who have a mental illness in the jails waiting for competency restoration. Last year, Representative Landgraf sponsored Mental Health Colorado's Psychiatric Advance Directives Bill, which became law and is now being implemented in our state. We are pleased to recognize Representative Landgraf at Mental Health America's Regional Policy Council meeting today.
I am honored to be recognized by Mental Health America as a legislative mental health champion. One of my priorities when running for the Colorado House of Representatives was to increase access to mental health. I am proud of the work we have been able to do in my first 2 years in the Colorado General Assembly. In my first session in the House, I introduced a bill to achieve parity with federal law for mental and behavioral health insurance coverage. The COVID-19 pandemic has demonstrated how necessary access to mental health care is, and we should continue to expand access to treatment. No one should forgo getting mental health treatment because they are worried their insurance won't cover it. I hope to continue this important work in the House because there is still much to do to ensure that every Coloradan has access to mental health care and no one is left behind. Thank you, Mental Health America, for honoring me with this recognition.
Greetings, lovely people. I am so pleased and honored to be here today to accept this recognition as a mental health champion. I serve on the Public Health Committee for the Colorado State Legislature, and it is just absolutely a privilege to be able to hear the really moving and important testimony to support legislation and to sponsor legislation around improving our mental health systems. In 2019, I sponsored mental health parity legislation here in Colorado, which mirrors the national legislation that's in existence, but really just provides us with additional accountability and enforcement because it really wasn't happening. And it's very, very important that if you have 10 providers in network for your health care, that you should have 10 viable providers in your network for your mental health needs as well. Similar co-pays and that kind of thing. So this has given us an opportunity to really keep tabs on it and make sure that it's happening here in Colorado. I've also, this session was pleased to sponsor a bill with my dear friend and colleague and former recipient of this award, Representative Daphne Michelson-Janae, on providing excused absences for kids calling in for mental health issues. You need a mental health day. It's now excused here in Colorado. So those kinds of, particularly those pieces of legislation, really speak to the need to normalize and destigmatize mental health issues. We all have them, and to the degree that we recognize that and break down some of those barriers, it's going to be easier for anyone to get the help they need. I was also working on a piece of legislation that I'll be eager to bring back next year called Jack's Law that addresses bullying in the schools and really provides the support and services for both the bully and the bullied. Obviously, there's a lot going on for both parties, and we want to bring some more accountability to the situation for the schools, but then also really focus on the kids and the help and support that they might need on both sides to get through the situation. So I am most appreciative of all of the wonderful colleagues I get to work with, partners in this work, such as my friend, Representative Michelson-Janae, Mo Keller and Lauren Snyder from Mental Health Colorado, and Rick Padilla, who I'm working with on Jack's Law and who became a suicide prevention advocate after losing his son, Jack. So thank you, Mental Health America. Again, I am very, very grateful for this and look forward to doing lots of more mental health legislation and good work in the future. We have a long way to go, and I'm really happy to be in a place to help move forward.
Hello. I grew up in San Diego in a military family surrounded by other military families. On occasion, my mother would talk about her brother Johnny, who had been sent home from serving in World War II due to what they then referred to as shell shock. I didn't understand this other than to know that Uncle Johnny had gone crazy. This was my introduction to mental illness, and in this case, what we now call PTSD. What I knew of mental illness was simple. It was bad. You never talked about it other than in whispers. It was untreatable, and in most cases, it couldn't even be diagnosed. People who were crazy were to be avoided as if it was contagious. It was something to be ashamed of. I grew up and married an Army man, and while the term shell shock was no longer in use, we have all heard of the Vietnam veteran who came home and disappeared into the mountains or simply onto the streets, and we never asked why. That was a long time ago. I'm very happy to say that things have changed. Not enough, but in the right direction. As everyone present knows, mental illness is still the most difficult illness to recognize, diagnose, and treat. It is finally being recognized as an illness that should be considered, treated, and insured like any other disease, but unfortunately is still one of the most difficult diseases to accept. There are not enough providers, facilities, or money. The stigma, while not nearly as bad as it once was, is still there. When we see people on the street having arguments with themselves in very loud voices, we avoid them. When we meet people addicted to drugs or alcohol, we label them as too weak to break the habit. If you are in the military and would benefit from treatment, you'd better be careful. The very slogan, Army Strong and Be All You Can Be, leaves no room for a perceived weakness such as PTSD. And if you are a kid being bullied or abused or just feeling isolated or hopeless, the answer way too often is suicide. Mental illness affects so many people in so many ways that it would take much more time than I have to even begin to address the shortcomings. Everything from network adequacy to provider reimbursement, getting the right people in the right place at the right time, literally saving the lives of children and adults. For this I am grateful. As I leave the legislature, it gives me great pleasure knowing there are people who will continue to move these issues forward, that slowly, one by one, these shortcomings will be addressed, and maybe, eventually, people like my Uncle Johnny won't be perceived as crazy, but rather sick with a treatable disease, accepted by society, and healed like any other treatable disease. It has been my pleasure to be able to move this conversation in the right direction for the last 8 years. This award is a great honor. Thank you.
Hi, this is Emily Vera. I'm the Executive Director of MHA in Delaware, and I'm here to introduce the recipient of the State Mental Health Champion Award, Senator Stephanie Henson of Delaware. We know Senator Henson in our small and mighty state as certainly a fighter for people with mental health disorders, someone who has worked very hard, particularly in regards to the opioid epidemic, to bring resources to those affected, to family members, to the whole community. And so we're very grateful for her work. She's been a leading voice in our statewide behavioral health consortium, which brings together stakeholders to address a variety of mental health issues. She has been a proponent of our newly developed overdose system of care. And she'll talk a little bit about some legislation that is bringing resources to our communities where they're really needed in response to the opioid epidemic. So we're thankful for all of her hard work, and thank you to the Regional Policy Council for giving us a few minutes to talk about our great little state. Thank you.
I'm State Senator Stephanie Henson from Delaware. I'd like to thank the Mental Health America Regional Policy Council for this Legislative Champion Award. It wasn't long ago that the major health crisis affecting Americans was the opioid epidemic. Now we have COVID-19 and its devastating effects on so many aspects of our lives, compounding mental health issues, and amplifying issues associated with opioid addiction and death. With the assistance of advocates such as Dave Humes with attack addiction and Mary Beth Shahaki, who have lost family members to addiction, strong partners in the state of Delaware's Division of Public Health, Division of Professional Regulation and the Attorney General's Office, a brilliant drug pricing expert from Johns Hopkins, and my House Prime sponsor, Representative David Bentz, we passed Senate Bill 34 in 2019, which created an opiate impact fee. Senate Bill 34 was about equity and justice. It created an impact fee that would be paid by pharmaceutical manufacturers on a per pill basis for their opiates that were sold in our state. The funds from that impact fee would be used to fund addiction treatment and prevention programs. The principle behind this bill was simple. If you bring a substance into our state that has a widespread detrimental effect on our citizens, then you are responsible for a fair share of the government's response to that effect. The impact fee is based on the strength of the opioid dispensed, referred to as the morphine milligram equivalent, or MME. The stronger the opiate, the higher the MME, so the higher the impact fee. This is appropriate because statistically, there is a direct connection between the quantity and strength of opioids prescribed and the rates of opioid addiction and death. At this time, we have approximately $750,000 in the impact fee fund, and our Department of Health and Social Services is in the process of determining how best to spend those funds, along with advice from our Behavioral Health Consortium, the Overdose System of Care, and the Addiction Action Committee. We're anticipating approximately $500,000 per quarter coming into the fund going forward. Meaningful change doesn't happen without a fight, and this was a 2-year battle on many fronts. However, with the strong partners I mentioned earlier and solid legal research on a number of constitutional issues, I believe we have put in place a system in Delaware that will change and save lives. Thank you again very much for this award.
Good morning. My name is Glenn Liebman. I'm the CEO of the Mental Health Association in New York State. I have the honor today of introducing Assemblyman John McDonald. He is so deserving of this honor bestowed upon him by Mental Health America. I was asked to say a few things about John, and I will tell you it's hard in a short time frame to talk about John like this because he has done so much for our community. He is the only pharmacist in the legislature, so he's very mindful of our issues around medication access, fail first, and all of those, and certainly he's become a strong advocate on that. But there are so many other issues where John is such a strong advocate for our community, around community services, around mental health education in schools, aging, working with veterans, suicide prevention, you name it. John is on top of it. And John is just on top of everything else, he is just so approachable and such a decent guy to work with. We are very lucky in New York State to have John as a legislator working with us in the mental health world. So I'm honored today to introduce Assemblyman John McDonald.
Hi, I'm John McDonald, and I am honored and humbled to be a recipient of this year's Mental Health America Legislative Award. Thank you to Mental Health America for presenting me with this distinction and for their continued work in promoting mental health and preventing mental illness through advocacy, education, research, and services. Throughout my time in the New York State Assembly, I have advocated for budgets, including workforce funding increases, funding for mental health education, and increases in funding for existing mental health housing. I am also the co-sponsor of a bill to require the Office of Mental Health, in consultation with the State Education Department, to identify or develop materials regarding the prevention of suicide for use by educators. I believe we need to make these materials available to bring awareness to the importance of early intervention, suicide prevention, and treatment of mental illness to all students that are in secondary school. As a pharmacist, I all know too well throughout my career the challenges individual mental health have. I also know the challenges that individuals with substance abuse have as well. And as we commonly know, many times these two disease states overlap. It's due to the work of Mental Health America, who brings the message to us legislators that helps inform us in public policy. And for this honor, I promise to continue to work toward our common goal of increasing mental health awareness throughout the state of New York and beyond.
Hello, I am Laurie Barnett-Levine, the CEO of Mental Health America of Southwestern Pennsylvania. I am delighted to be able to present to you today a legislative champion, State Representative Michael Schlossberg of the 132nd Legislative District in Pennsylvania. Representative Schlossberg spoke about his own experiences with mental health, including depressive disorder, anxiety disorder, and at times even suicidal thoughts. He recently told me that this is one of the most successful things he has done for his career by coming forward. He has been embraced and supported by constituents and the community. Representative Schlossberg was recently appointed by Governor Wolf to co-chair the Suicide Task Force for Pennsylvania. He is co-founder and co-chair of the Mental Health Caucus for Pennsylvania and the secretary for both the Health Committee as well as the Human Services Committee for Pennsylvania. Representative Schlossberg has been passionate in his advocacy about mental health around issues like funding and parity. We are very grateful to have such a champion in our midst. Thank you.
Hi everyone, my name is Mike Schlossberg, State Representative for the 132nd District, representing the City of Allentown and South Whitehall Township in Lehigh County, Pennsylvania, and I want to sincerely say thank you. Being awarded the Legislative Champion Award from your organization means a great deal to me because it's an acknowledgement of the good things that can happen when you're honest with who you are and when you fight for people who need it. In 2014, I began talking publicly about my own struggles with depression, with anxiety, and with being suicidal at points in my life. That work led me to get more active in the area of mental health. Since that time, I've appeared in anti-stigma commercials, I've passed legislation related to suicide in colleges, making sure that first responders had more access to mental health treatment. I also co-founded and now co-chair the Mental Health Caucus, a group of Pennsylvania legislators, Democrat and Republican, that work together to try to advocate for mental health issues. This award is a reaffirmation. It shows that good things can happen when not only are you honest with who you are, but when you champion the needs of people who desperately need it. I wish we could all be together. Obviously, this is a little bit of a difficult moment in history. But from the bottom of my heart, I want to say thank you. When I'm lucky enough to be acknowledged for my efforts related to mental health, it reaffirms that the decision that I made about 6 years ago was the best thing I ever did in my life. Thanks to all of you for the work you have done for decades, and here's to decades more years of working together.
Chairwoman Thompson has spent almost 4 decades in the Texas legislature, fighting for Texans' healthcare, education, and social justice. Known now as Miss T, she's earned the respect of everyone, legislators, staffers, and constituents alike, under the Great Pink Dome. Quite often, I've seen a number railing against the bill at the back mic until they saw Chairwoman Thompson approaching, when they quickly stepped away and ceded the mic to Miss T. She is a legend, a change maker, and has made a mark on Texas's history, never to be forgotten. Mental Health America has myriad reasons to nominate her for any and all awards. She is deserving of each and all. This year, we thank her for offering House Bill 906 during Texas's 86th legislative session. During Hurricane Harvey and the shooting at Santa Fe High School outside of Houston in May of 2018, Chairwoman Thompson understood the importance of designated unprecedented funding to school districts to create safe and supportive environments, helping children heal and hopefully preventing future incidents. As a very wise legislator, she also realized that such an investment had never been made and would need to be evaluated for efficacy and taxpayer accountability. HB 906 passed overwhelmingly. I am now lucky enough to chair the task force it created, and where we study which state programs are working, which ones might not have been as successful of an investment. The task force will present its first report to the legislature in November. It hopes to ensure students and taxpayers receive the most benefit from the state's programs. Sinfonia Thompson drives legislation that benefits all Americans, and we are so lucky and grateful to partner with her to create legislation that not only provides additional services, but also impacts services that will positively impact the Texas students. We could laud her for so many things. Today, I'll simply say, Ms. T, you are our champion.
Hello, everyone, and thank you so much for allowing me to be with you this afternoon. I really appreciate it, even though it's virtually. I wish I was there with you in person. I want to take this opportunity to thank Mental Health America for the outstanding work they did last session in helping me pass House Bill 906. This is a bill where we're going to be able to study children in public education and be able to see whether or not that we can create safer environments and have better mental health outcomes. In addition to that, allow me to please thank those persons that Texas Education Agency has assembled as a task force who care a lot about kids and who want to make sure that this remain a focal point and we have a safer environment and better mental health outcomes for all of our students. I am so honored that Mental Health of America allowed me to be the champion of mental health last session of the legislature and are giving me this award. I sincerely appreciate it. There are a lot of things that we have done, but there's a lot of work still to be done. And ladies and gentlemen, I just want you to know I am so happy that we're keeping mental health as a focal point because we want children not only to have a healthy physical body, but we want to have a mental healthy body as well. Again, thank you so much for this outstanding champion award that you bestowed upon me. I'm humbled with your kindness and generosity. And remember, stay safe, keep your social distances, wash your hands, and don't forget to mask up. Thank you.
This is Bonnie Cook, and I'm the Executive Director of Mental Health America of Greater Dallas. It is my privilege to introduce Representative Forprice. Representative Forprice is a fourth-generation Texan from Amarillo. He is serving his fifth term in the House of Representatives, and he is a legend within the halls of the House of Representatives. In January of 2019, Representative Price was appointed to chair the House Calendars Committee. He also was selected to continue to serve as a member of the House Natural Resources Committee and the House Public Health Committee. He continues to co-chair the Health and Human Services Transition Legislative Oversight Committee. After the tragic shooting in a Walmart in El Paso, Texas, he was also asked to serve on a committee to look at gun violence and safety within Texas. In 2018, Representative Price was also chair of the Select Committee for Mental Health. This Select Committee Mental Health's report is a report that we still use to this day to look at issues related to mental health services within Texas and to identify gaps in services and ways that we can treat those with mental illness within Texas. When I first talked to Representative Price 2.5 years ago, I picked up the phone to call him and expected an aide to answer the phone. So I dialed the phone number. He picked up the phone. It threw me for a loop that this representative who chairs so many committees and works so tirelessly for those of us in Texas, I couldn't get my words out. He was very gracious, very patient as I fumbled through my introductions. He is someone that cares about those with mental illness. He cares about us as advocates. He cares about us with mental illness. We in Texas are beyond blessed to have him as someone who's in our corner. Thank you so much, Representative Price, and we are pleased to nominate him for this award.
Hello, I am State Representative for Price, a member of the Texas House of Representatives. For several legislative sessions, it's been my privilege to work side by side with many mental health advocates in Texas, including the Texas affiliates of Mental Health America. Our ongoing efforts have strengthened the delivery of mental health services along with providing additional state resources. Also, we've improved the delivery of services in the justice settings. I am particularly proud of what we accomplished in the nexus between mental health and public education. Last session, the Texas legislature also made significant investments in partnering with our state university health science centers. I'm honored to be named a legislative champion by Mental Health America, and I thank Mental Health America of Greater Dallas for nominating me for this prestigious recognition. Let's continue to strengthen the delivery of mental health services in Texas. Thank you.
Wow, they are really amazing. I'm so proud to be able to say thank you to these mental health champions. You can see why we get excited about each time we get to say thank you to wonderful legislators all across the country. And over the years that we have been having this award and this award ceremony, we know that the legislators are listening and learning from each other. And that means a great deal to us as well. So we're able to do things like have them talk about the wonderful legislation that they have, like Steve Ellison, how he has been inspirational for many things and many things across the country. You'll hear much of what Steve talked about come up in our policy meeting that we're going to start early because we have so much to pack in. We're going to start at 11:55 Eastern time. But before we take a break and before we move into the main policy meeting, we'd like to share with you one of Mental Health America's priorities for peer services. And we're going to hear from Mental Health America's advocacy manager, Karen Howard. But I just want to say, I want to take a second to say thank you to Karen. Whether our meetings are in person or virtual, they wouldn't be happening and they wouldn't be successful without Karen's behind the scenes work. She's the one who sets up all of the registrations, gets everything going, sends the letters out, troubleshoots, and so many other things. And that's just a very, very small part of who and what is. And please allow me to introduce her and to hear about another really important legislative priority for Mental Health America. Karen?
Hello, I'm Karen Howard, the Advocacy Manager at Mental Health America, here with a short message for you on peer support. What is peer support, you ask? Peer support is the process of giving and receiving encouragement and assistance to achieve long-term recovery. It's an evidence-based practice that has existed in behavioral health for decades. Who delivers peer support? Peer support specialists deliver peer support and are individuals with lived experience of mental health conditions and/or substance use disorders who use a combination of their lived experience, knowledge of systems and services, and formal training to support others in their recovery. For years, peers have worked in state psychiatric hospitals, community mental health centers, and peer-run organizations. And recently, there's been rapid expansion of peer support across other settings that include primary care offices, emergency departments, addiction services, mobile apps, inpatient psychiatric units, colleges, and jails and prisons. Wherever there is a need, peers can help provide the hope, skills, and resources that move people from disability to ability. Over 30,000 peer specialists provide services in the U.S., resulting in dramatic cost savings to payers and systems. While peer support is Medicaid reimbursable in over 40 states, it is yet to expand to Medicare and private insurance due to inconsistencies in training and required experience across the states. Now, how helpful is peer support? Research and experience show that peer support specialists have a transformative effect both on systems and individuals. Evidence that is quantitative and qualitative indicate that peer support lowers overall cost of mental health services by reducing rehospitalization rates and the number of days spent in inpatient settings and increasing the use of outpatient services. Peers also help people engage in the medical system when they may be otherwise inclined to avoid or mistrust visits with clinicians. When working with individuals with mental health conditions, peers have been shown to reduce rates of emergency service use while improving quality of life and management of co-occurring health conditions. Do peer support specialists really save money and improve care? Well, yes. Widespread shortages of behavioral health providers across the country leave many Americans without access to any services. Half of U.S. counties have no behavioral health providers. This means that these individuals often go without supports that could prevent the costliest outcomes, like disability, hospitalization, incarceration, and homelessness or joblessness. Here are some examples of how peer support has worked. A peer support program in Pierce County, Washington, reduced involuntary hospitalizations by 32%, leading to a savings of nearly $2 million in 1 year. A federally qualified health center in Denver found that using peers saved $2.28 for every dollar spent. Third, a New York-based peer support program for individuals transitioning from inpatient services back into the community resulted in a 47.1% decrease in behavioral health costs. And fourth, a meta-analysis of randomized controlled trials on peer support demonstrated that peer support is more effective than usual care in reducing depression. Now, what are the limits of peer support? In the workforce, training requirements vary state by state, even county by county. A range of experience is required for employment. There are few opportunities for advancement, and there's a lack of advanced training on topics like whole health, which are necessary to move forward with trends in behavioral health. So, that is why Mental Health America created the NCPS, a National Advanced Certification for Peer Support. MHA has also drafted model legislation to recognize a national standard which builds on top of existing state certifications. This draft legislation can be adopted by any state. 40 hours of training and 3,000 hours of experience is required for the national certification that MHA created. And it's designed to be an advanced certification that does not replace, but instead builds upon existing state certifications to allow private insurers to more easily support integration of peers into workflows. Currently, there is too much variation in standards across the country for private insurers to really reimburse for peers. So our model legislation addresses these concerns by establishing a standard that will reflect the professionalism of the field. It can be adapted in all states and moves us towards a system of tiered levels of peer support. Some state leaders have already begun discussions to introduce legislation, this model legislation, or make regulatory changes based on the model legislation to recognize the advanced certification. To learn more about how you can get this legislation introduced in your state, contact me, Karen Howard, at choward@mhanational.org. To learn more about MHA's national certification or about the work and career of peer support in general, visit MHA's Center for Peer Support at www.centerforpeersupport.org. Thank you so much for taking time to be at MHA's RPC meeting. I hope you enjoy the rest of it.
Thank you so much, Karen. We appreciate all your work behind the scenes and your important work in helping us move forward our priority of peer support. We'll be hearing much more about peer support. We'll be hearing much more about the themes that you have heard from the legislators, plus really important ways to overcome inequities, how we can do amazing things together. And we'll hear some examples of wonderful programs and models that are happening across the country. We're going to take a stretch break. We're going to take a 5-minute stretch break here because we've got so much. We will look forward to meeting you back here in 5 minutes to begin the main part of our policy meeting. So please go take a stretch, get a cup of coffee, and we'll see you back here in 5. Thank you. Hello and welcome back, or welcome if you're joining us for the first time. I'm Debbie Plotnick. I'm Vice President for State and Federal Advocacy with Mental Health America in our national office, and we're so delighted that you could join us today. And I'm going to tell you a little bit about this meeting, about the Regional Policy Council. But the first thing I want to do is say thank you to our very, very important sponsors, without whom we wouldn't be able to be here with you today. So again, a big thank you to Allergan and Alkermes and Janssen and Myriad and Neurocrine and Otska, the Takeda-Lundbeck Alliance, and Teva. The Regional Policy Council coordinates MHA affiliates all across the country, and it's led by 4 outstanding policy champions. And if we were in person, and I wish we were because I miss greeting all of you and hugging you and having you be present with our wonderful RPC representatives who host all of our meetings. And we break them down into clusters. And for what would have been 2 summer meetings, we've combined so we can go virtual. We have our wonderful policy representatives, Harrington and Shannah, Mulvihill. I'm going to tell you a little bit about the work that Ben and Shannah and our other RPC reps do. And you're going to hear from Ben and Shannah in a minute. Between them, they have over 50 years of experience running nonprofits and doing amazing work. They're outstanding policy experts in their state. And what they do at Mental Health America as regional policy reps is they help bring our advocates and our advocacy network all across our affiliate field together to learn about what's happening in the states and to coordinate that with federal initiatives. So we are all a team, and we are so happy to have them. They're going to set the stage today for this really important meeting. I'm going to introduce them right now. You're going to hear from Ben Harrington and from Shannah Mulvihill.
Good afternoon, everybody. First, I just want to thank everyone for joining us here today. This has been an exceptionally busy time for so many of us working in the mental health arena, as we've seen increased need. So we really appreciate the fact that you've chosen to spend a few hours of your valuable time with us here today. Second, I have to say that while I'm truly happy that we're able to make this RPC meeting work virtually, I do really miss the fact that we can't get together in person. I really look forward to RPC meetings as well as the national conference as opportunities to connect with others who deeply care about mental health, share ideas about how we can do better for those who need help. I also look forward to seeing so many other affiliate leaders who I've come to count on, not just as colleagues, but friends. That being said, we do have a terrific lineup of presenters here for you today with topics that are both timely and essential for us to address. COVID-19 has interrupted nearly every faction of our lives and work. It has also shone a light on the deep inequities that exist in our healthcare system, in our ability to address mental health needs, and frankly, in the world as we know it. Many of us have scrambled over the last months to address those needs and find creative ways to meet the needs in this challenging environment. Then, as we struggled with the pandemic and emerging mental health needs in so many communities, there was yet another crisis. On May 25th, George Floyd was murdered by a police officer on a street in Minneapolis. To watch this happen in a city I knew and loved was incredibly painful for people here in Minnesota, around the world, and frankly, for me. Suddenly, a state and city I had called home for more than 20 years was the focus of worldwide news. Buildings and neighborhoods around our organization's office burned to the ground, and so many of us felt shame and sorrow where we once held pride in our Midwestern roots. But today, I look forward toward the future because we can do better. Tens of thousands of people have stepped forward over the last couple of months and said, this is not the world we want to live in, and we're going to change it. We can all work harder to recognize the impact of systemic racism in our world and make the changes needed to ensure that all people with mental health needs get the help they deserve. There are so many talented people here doing good work. And I hope today's meeting will inspire us all to continue to step back and look at our communities and mental health needs with an eye toward equity and accessible treatment for all. Thank you. I hope you'll enjoy the sessions today, and I'll turn it over to Ben.
Good morning. My name is Ben Harrington. I'm the CEO of the Mental Health Association of East Tennessee, and I'm an RPC representative. We're very glad to have you with us today. And like you, I'm sure we all wish we could have seen you in person at a meeting, whether it was in Indianapolis or in Orlando. But as you know, when life gives you lemons, you got to make do. And so you make lemonade, and that's why we're here virtually. And we look forward to today. 2020, as my friend Debbie Plotnick frequently says, is indeed a cluster. It's a hot mess. I know what I planned to do on my bingo card was fundraise, grant write, plan events, plan conferences, that sort of thing. But I never planned, and probably none of you in the audience today, planned for 2020 to be such a hot mess, such a cluster, as Debbie said. We're dealing with the pandemic, we're dealing with the economic meltdown. We now are having to face significant health disparities. We're dealing with racial trauma, and of course now we are continuing to have seriously tragic instances of excessive use of force by police. But you know what? We're still standing, we're still here, and you know why? It's because MHAs are resilient. Actually, we've been through some of the same things before, or maybe somewhat similar things before, and that's why we're able to be so resilient. I know some of us have done some disaster mental health work, particularly the affiliates in the Gulf Coast area, Texas, Mississippi, Louisiana, the Florida affiliates along the East Coast. Midwest has had to prepare and deal with response for tornadoes because we're in Tornado Alley. That sort of thing is transferable and helps us be much more ready and able to respond, especially to something like a pandemic. If you've been around for a while and you were in your affiliate in 2008, you responded to the economic meltdown that happened then. And those things prepare us, and they teach us well, actually, what to do. We all had to, in those days, dive into our budgets, figure out exactly what were needs versus wants. And we had to do that both personally as well as professionally. But events are now telling us we've got to focus on some other things too. And we've got to confess that we've probably all been very poorly prepared to help our communities grapple with health disparities. Health disparities have deep historic roots in terms of the way people have been treated because of their race, whether they got access to healthcare or whether they did not, whether folks could trust healthcare professionals or not. So those roots are indeed deep, but I've got to tell you something too. Those roots are also fresh. They're in the present too. And see, the pandemic has made us understand that health disparities are present today. And they're going to continue unless we look for ways to work around healthcare disparities and make sure folks get access to care. The current roots of disparity exist to access to care and, of course, access to Medicaid. and are present in so many states, like my own, that did not expand Medicaid. So was that a political decision, or were there really some deep-rooted racial issues involved in the decision to make Medicaid access not be so readily available to persons of color? And so those are issues that we're struggling with and we're grappling with, and we have to address them today. Now, of course, racial trauma is something that we've experienced too. And maybe it's news to some people, maybe it's not news to many others on the conference today. But we don't live it every day. Those of us who are white and are privileged, we don't live with racial trauma every day. We don't experience those things. You know, the instances are real and long-lasting and deep-rooted. You know, some people are going to confuse racial trauma with PTSD. We can't allow that to happen. If it's an instance of a traumatic event, then there is a little bit of similarity, but racial trauma really is about the compounding compilation of trauma, of toxic trauma. And so I'm a white male. That was not part of my journey. I have not experienced that. And so I can't necessarily say, oh, I understand that. What I can say is, oh, I have a whole lot to learn so that I can best support people in my community. Clinically, I can understand clinical trauma issues, but I didn't live that journey that so many other people have lived because I am indeed privileged. You know, as a white male, I applied for loans for cars, for housing, that sort of thing. I never had to worry about the color of my skin being an influencer as to whether I got that loan. You know, I never had to worry when I bought my house about moving into the neighborhood and worrying that people are going to turn their heads and be concerned about, oh, it's a white man moving into the neighborhood or a white family who moved into the neighborhood. I didn't have to live that journey, but so many people do have to live that horribly traumatic journey just because of the complexity of their skin. And you know, I'm also so privileged because my kids never had to worry me at night for being out driving and getting pulled over because of the color of their skin. So I am indeed privileged, and this white privilege has shielded me and shielded my family. And so I can't say I understand racial trauma because I never had to live it, but I can say I've got to learn from my existence, my privileged existence, and figure out how I can be a much better human. And so recent events have reminded us that really not much has changed in not only the past decades, but really for hundreds of years. Now, some folks are going to use a phrase very, I guess, weakly and try to claim that time has healed old wounds. That is such a myth and such a lie. Time hasn't healed wounds. Realistically, time allows old wounds to be forgotten or allows the deniers of truth or the minimizers of truth to find ways to reshape it, reframe it, rewrite it, and let issues that have arisen kind of fall by the wayside. So the wounds are still there. They're really waiting to be reopened. And we know that old wounds have been reopened. And, you know, those wounds are there because we've been very lazy as a society. The wounds are there because we're all guilty of looking the other way. The wounds are all there because we've denied the problems that have existed or the events that have existed are our problems. Yep. And they're there because we've minimized the events in the past. There have been folks that have said, oh, this is the only time something has happened. Well, that's minimizing it, trying to make it sound like it's not as tragic or horrible or as important an issue to address. And so we've been lazy. We didn't do the work that we needed to do. And so that's what today is about. Today is a big day for us here as mental health stakeholders. It's a big day as MHAs. So I'm glad you're here. Roll up your sleeves. Let's get to work because we have a lot to do.
Thank you, Ben. Shannah. You can see why it's so important to work with a team. I love working with our RPC reps, with Shannah and Ben and Mo and Barb, who aren't hosting this meeting, but who are also our RPC reps. And it also takes, as I've said before, the team behind the scenes. Thank you, Karen, for doing everything that you've done. And I want to do just a little bit of housekeeping before we move on. We will be able to have engagement with our audience. We'll have Q&A for some of our speakers, and we really appreciate that. And we wouldn't be able to do the kinds of things that we're doing virtually as we all learn together in this new world of virtual meetings. I want to say thank you to our behind the scenes virtual team, to Sachin Doshi, to Catherine Reynolds, and to our consultant, Amanda Adams Barney. It takes that team. And it takes us to all work together to look at these really hard truths that we are about to go through for the rest of the day, and to really give us some context for how the inequities that are coming forth that we must pay attention to, as Ben said, are affecting us, is our colleague, Maddy Reinert. Maddy is a wonderful member of our team, and sometimes I think of her as our data guru, and you're about to see why. Maddy, please tell us about how the epidemic and what has been going on are affecting the folks that we care about.
Hello, everyone, and thank you for joining us today. I'm Maddy Reinert, the Program Manager of Population Health at Mental Health America, and today I'll be walking through the data that we've collected from the over 900,000 screens taken through the MHA screening program this year, and exploring what that tells us about the mental health crisis our country faces so that we can continue to be responsive and better support people both during and after COVID-19. So all of the data I will be discussing today comes from the MHA online screening program, which is a collection of 10 free, anonymous, confidential, and clinically validated screening tools that allow people to explore their mental health concerns online. So each of these screens are the same tools commonly used by healthcare providers to test for mental health conditions in a doctor's office. And we put them online because we know that when people first start experiencing symptoms of mental health problems, they turn to the internet for answers, the same way we often do for our physical health. So when people turn to Google to find help for the mental health symptoms they're experiencing, they can take a screen and immediately receive results, resources, and supports online, often long before they're ready to receive treatment or take their mental health concerns to a provider. So since its launch in 2014, over 5.5 million people have come on and completed a screen, making this the largest data set ever collected from a help-seeking populations for mental health conditions. And the results help us understand people who are struggling. So what are the particular mental health problems that people are facing? Why are they coming to our site to take a screen for their mental health? And how can we best provide them with resources and supports that are most relevant to them? And as we've increasingly seen with the COVID-19 pandemic, it allows us to answer these questions as people are struggling, as they're actively taking screens, so we can recognize and respond to changes and trends in the mental health of our nation in real time. And so the resources, supports, and policy decisions that we're making can be based on what we're seeing right now throughout the country, not months or years later. And part of how we understand these trends is by including optional demographic questions when someone takes a screen, which the majority of our screeners do answer. So from those, we know that our screening population is young, with almost 2/3 under the age of 25. 72% identify as female, and they're a help-seeking population that's struggling with moderate to severe symptoms of a mental health condition. So on average, 74% screen positive for the condition for which they're taking a screen. We also know that many are receiving this information for the first time. So of those who screened positive for a mental health condition in July of this year, 68% had never received a prior diagnosis, and 64% reported that they had never received any kind of treatment or supports for their mental health before. So prior to 2020, we had about 1 million people a year, which is about 3,000 a day, come to MHA screening to take a mental health screen. But since the COVID-19 pandemic really took hold, and with the ongoing social unrest and trauma that people, particularly Black, Indigenous, and people of color, are experiencing as a result of police brutality and racism in this country, we've seen an unprecedented increase in the number of people searching for help online and taking mental health screens. So in July 2020, nearly 50,000 people took an anxiety screen, which was over 1,600 per day, a 420% increase in the per day average from January, so before COVID-19 had really started spreading in the United States. And this increase was not just limited to anxiety. So in July, we saw an even larger increase in depression screens, with over 85,000 people taking the PHQ-9 for depression. So that comes to nearly 3,000 depression screens per day in July, a 520% increase over January. And if you remember, prior to 2020, we had about 3,000 screens taken per day across all screens. So this was a huge increase. And while these increases in people taking screens are staggering, what's even more indicative of the magnitude of the mental health crisis that we're facing are the results of those screens. So with mental health being discussed more in the media and with campaigns like May is Mental Health Month, we expected more people to be taking screens, so to check in on their mental health. But we also expected that if this increase was just because of media exposure or more people becoming curious about their mental health or feeling worried or anxious at a time when it's impossible to not feel worried or anxious to some degree, we would see the rate of people screening with moderate to severe symptoms decreasing. But what we've seen is that this increase in screens is not the worried well, but that even as those screening numbers have skyrocketed, the severity of those screens has worsened as well. So in July, the rate of people screening with moderate to severe depression is the highest it's been throughout this year. 85% or over 72,000 people who took a depression screen scored for moderate to severe depression. And we saw the same for anxiety. So the rate of people screening with moderate to severe anxiety also peaked in July, with 79% or over 39,000 people who took an anxiety screen scoring moderate to severe anxiety. And 48% actually screened with symptoms of severe anxiety, which is also the highest rate we've seen during COVID-19. So we're really not seeing this mental health crisis slow down in any way. We're actually just seeing it accelerating month by month. And we're seeing it affect young people particularly severely. So throughout the COVID-19 pandemic, 11 to 17-year-olds have been the most likely to screen for moderate to severe anxiety and depression. And in July, we saw that 83% of 11 to 17-year-olds who took an anxiety screen and 91% who took a depression screen were scoring with moderate to severe symptoms. And suicidal ideation is also being reported at staggering rates. 36% of people who took a depression screen indicated that they had serious thoughts of suicide more than half or nearly every day in the past 2 weeks. So that's more than 30,000 people who contemplated suicide or self-harm in the month of July alone, which is also the highest number that we've seen since the beginning of screening in 2014. And we can see from this trend line that unless we do something, it's only going to continue to get worse. So we've only seen it increasing. So as we were continuing to see this growing mental health crisis unfold throughout 2020, we wanted to know more about exactly what was driving the increase in mental health concerns. So we believed it was because of the COVID-19 pandemic, but we weren't able to draw that conclusion until we asked. So in April, we added a question to our demographics that asked about the top 3 things contributing to a person's mental health concerns as they were taking a screen. And among people who screened at risk for moderate to severe anxiety, consistently the top 3 concerns have been loneliness or isolation, past trauma, and relationship problems. In June, we added racism as an option under this question, and 10% of people who screened for moderate to severe anxiety responded that racism was one of their top 3 concerns. Among people who screened at risk for moderate to severe depression, the top 3 concerns were the same. And in July 2020, 8% of people who screened for moderate to severe depression and answered this question responded that racism was one of their top 3. But while the top 3 concerns have remained the same, we have seen some changes over time. From May to June and July, we did see the percent of people concerned with loneliness or isolation increase. And we also saw anxiety and depression surrounding coronavirus decreased in June, which was directly mirrored by an increase in people citing current events as their reason for taking a screen, suggesting that the ongoing police brutality and social unrest that we're seeing throughout the country may actually be starting to affect mental health even more than the pandemic. And we've also seen that these concerns don't affect everyone equally. And the differences reveal some of the inequities that BIPOC communities in particular face in the United States that directly affect their mental health. So across May through July, we saw that Black or African American screeners who screened positive for a mental health condition were 5 to 6% more likely to cite financial problems as a main concern than other racial or ethnic groups. We also saw that Native American or American Indian screeners are more likely to report past trauma as a main concern affecting their mental health. Hispanic or Latino screeners are about 1 to 2% more likely to report coronavirus as one of their top 3 concerns and have consistently reported loneliness at a higher rate than other racial or ethnic groups at 75%. But from June to July 2020, the largest increases in reporting loneliness as a main concern were actually among Black or African American and white screeners at 5% and 4% respectively. So while each of these concerns affect everyone and we're seeing them reported widely across race and ethnicity, these differences reflect some of the huge systemic inequities that BIPOC communities are facing. For example, while financial concerns are affecting large swaths of the US population, we can see that they're affecting the mental health of Black screeners more. Likely because of the economic inequities that Black communities face as a result of systemic racism in the US. So while these inequities have existed for some time, the COVID-19 pandemic has really begun to highlight them, and they're exacting a very real toll on mental health in the US that we have to address. So thank you all for your time today, and as we move forward into the day and have discussions about our policy priorities, innovative programs that are being implemented on the ground throughout the US and what we can do moving forward, I hope that this information and the urgency of the growing mental health crisis can guide us in working to eliminate the systemic inequities people are facing, act quickly to address population mental health, and create better treatments and supports as we continue to experience this pandemic. So thank you.
Thank you, Maddy. We're going to take a literal 1-minute stretch break as we get ready to move into the meat of the meeting. And so while we're stretching, get ready for this really hard work that we're about to do. The next few speakers that you will be hearing from, you will be able to engage with at the end of their remarks. We'll have question and answer. So everybody, let's take a stretch, let's take a deep breath, and we'll see you in 1 minute. Welcome back. We really did mean 1 minute. We're so glad to have you. And it's really my great honor and privilege today that we have Dr. Arthur Evans with us to offer us a keynote address. Dr. Evans is the CEO of the American Psychological Association. You can read his whole biography on your feed earlier. It's all there. And of course, he is so amazingly well recognized both nationally and internationally. He's the recipient of numerous awards. But I want to talk a little bit about how I know Dr. Evans and my feelings about Dr. Evans. Dr. Evans loves Philadelphia almost as much as I do. And I know that from his 12-year tenure as Commissioner of Behavioral Health of the department in Philadelphia while I had the privilege of working there. And while Dr. Evans was there, he did something remarkable. He shifted the entire paradigm of what it is that a public behavioral health system can, how it's thought of and for whom it is focused and how it's delivered and for what it stands for. This can clearly be seen in the name of the Behavioral Health Department under Dr. Evans. It was the Philadelphia Department of Behavioral Health and Small Dis and Big Abilities when it came to intellectual disabilities. Under this system, when Dr. Evans was commissioner, he employed a population health approach that he'll tell you more about in his remarks. And he exemplified, brought to life, Mental Health America's before stage 4 philosophy, concentrating on all of the people, but making sure to put resources into early intervention rather than only focusing on people when they were in crisis with very high needs and very great individuals to families, taxpayers, and our communities. Please enjoy and listen carefully and see why Dr. Evans is one of my heroes.
Hello. First of all, thank you for inviting me to speak today. I hope that all of you are well and are safe. So I'm going to talk today about a population health approach to address the perfect storm of behavioral health challenges. And what I really want to do, and I know that many of the people that are watching this presentation are people who work in the public policy arena and are advocating for public policy. The basic premise of my talk today is I think this is an opportunity for us to shift how we think about our public policy advocacy. And I'm going to suggest to you by the end of this presentation ways that we can advocate differently in a way that I think will be much more effective for addressing behavioral health issues. And I'm going to talk about behavioral health. I'm going to talk about both mental health and substance use conditions. I'll just talk about it from a behavioral health standpoint. So let me first start out by describing what I believe are the challenges with the current behavioral health care system and the current approach that we've taken to behavioral health in this country. And I want to suggest to you, first of all, that behavioral health conditions are ubiquitous, they are complex, and they create a significant impact on communities and our society at large. I want to further suggest to you that our public policy does not reflect our best scientific understanding of behavioral health conditions, our professional understanding, and most importantly, what people with lived experience tell us in terms of what their needs are and how they experience behavioral health conditions, that those things are not reflected in the approach that we take. And as a result, we have a lot of unmet needs and a lot of challenges that I know most of the people listening to this will understand. So the bottom line is that we need to better align our public policy, what we're advocating for. We need to advocate our approach to behavioral health conditions with our scientific understanding of behavioral health conditions, what our experience tells us, and then again, what people with lived experience tell us they need. Now, if you add to that the issue of the COVID-19 pandemic, it clearly has exacerbated the challenges that we have. I would suggest to you that COVID-19 has created really a perfect storm of issues that are going to have a long-term impact on behavioral health conditions in our nation. We know that the pandemic has brought with it a lot of uncertainty, a lot of fear, a lot of anxiety, a lot of grief and loss that people have experienced, that all of those things are related to our behavioral health status. But we at the American Psychological Association have talked about the pandemic not just in terms of a pandemic, but a syndemic, because we recognize that underneath this pandemic are long-term structural and societal issues that are playing out in ways that this pandemic is having a disproportionate impact on certain communities, on certain marginalized communities, in particular communities of color, that it is a much more complicated set of issues that we're grappling with because of these structural and societal inequities that we have that have been layered on top of, the pandemic has been layered on top of. But in addition to all of that, which in and of itself has created significant behavioral health conditions, we have a significant economic downturn where people have lost their livelihoods in terms of their businesses, in terms of their jobs. And we know from a lot of historical data that there are always increases in psychological distress and needs when there's an economic downturn. And then on top of that, we've seen more recently the challenges that we have and continue to face in this country around race and racism, structural inequities and structural racism, and that has also created a significant amount of stress in the general population, which our Stress in the America survey has shown, but also in terms of the African American community and communities of color, in particular Asian community as well, when we look at some of the discrimination that has happened to that community. So we have a perfect storm of issues that have really exacerbated the behavioral health challenges that already existed. And we know and we expect that there are probably going to be increases in deaths of despair, suicide, overdose, those kinds of deaths of despair that have been well documented. There are going to be increased needs on a behavioral health system that is already taxed and was not able to meet all of the demands and needs that we've seen historically. And we're going to see increased general psychological distress within the population. So the question for us is, what should our advocacy agenda look like, given all of this? Do we advocate for more of what we have had, or is this an opportunity to advocate for what we need? So as I said, I'm advocating that we use this as an opportunity to change the paradigm that we have historically had and to better align what we are advocating for and what we do with that. So if I'm going to ask you to take on a new paradigm, I at least ought to tell you what I believe the current paradigm is. And I want to suggest to you that the current paradigm is a black box paradigm. And the way the black box paradigm works in our field is this. We create a black box called treatment. It could be a community mental health center, it could be a residential program, it could be a private practice office. And the way the paradigm works is that once we've created that black box, what we ask people who have behavioral health conditions to do is to come to us, we diagnose them, we figure out what's wrong, we treat them for what's wrong, and then we discharge them with the assumption that people are well and that from there they will derive the outcomes that they were seeking when they came to us for help. Now, if we were together, this is the part of my presentation that would be the audience participation. And I would say to you, what are the challenges based on our scientific understanding of behavioral health conditions, based on your experience? What are some of the challenges with this as the mental model for how we think about how we help people with mental health conditions? And I've done this literally around the world, in Australia and in Europe and all over the United States. I've done it with practitioners and with policy people. I've even done this exercise with journalists. And it is really, really interesting. It doesn't matter where you are in the world, what group you're talking with, people come up with pretty much the same issues. People are pretty clear that this is a mental model has some challenges. So if I were to ask you that, here's some of the things that you would probably tell me. You would say, first problem is that people who have behavioral health conditions don't always voluntarily seek out treatment. We know that because only half the people with a mental health diagnosis will get mental health care, or less for a lot of populations, and only 10% of the people who have substance use conditions will seek out treatment and get treatment. We know that many of the people that come don't stay. So the modal number of outpatient sessions, for example, is 1. That means the most frequent number of outpatient sessions, if you looked at all the people in a treatment program, the most frequent number that you would see is 1. So people come and they drop out pretty quickly. We know that people would tell me that, you know, it's a box and we treat people pretty much the same way. So the box works the same way in Manhattan as it does in Alaska, as it does in the rural South in Mississippi, that you create the box and then we expect people to fit the box, and that if people don't fit the box, we will put the onus on the person and we will say that the person isn't ready for treatment, they are treatment recalcitrant. We have all kinds of verbiage in our field to describe people who don't fit into the box that we create. And we treat people pretty much the same way. And heaven forbid if you have one condition and you go to the wrong box. So if you have a mental health condition, but what's really underneath that mental health condition is untreated, or you have a substance use condition and you are seeking out substance use treatment, but what you really have underneath that is an untreated mental health condition, that you may or may not have that addressed, because each box treats people based on what their treatment protocols are, not necessarily what people are seeking. You would point out to me that when people leave, that people are not, quote, fixed, because mental health conditions, substance use disorders are chronic conditions. They're more like diabetes. This is an acute care model where we assume that when people finish treatment that they're well. It's not like treating a broken leg. It's more like treating diabetes, and people need ongoing help. And what people will tell you, people, particularly people who have serious mental illnesses, they will tell you one of the things that they fear is that they're going to get so better, they're going to get so much better that the services that they're receiving are going to be taken away from them, because if you don't have a diagnosis, you don't get care in our healthcare system, which is really a sick care system. It's not a healthcare system. We focus on illness. We don't focus on health and treating illness. So what you would say is a lot of challenges with this as a mental model. And this is the way most of us were trained, whether we're psychiatrists or psychologists, social worker, most of us were trained on this as the primary way to help people. So in addition to all of the things that I've talked about, and there are many more, but I've just given you a sense of some of the major challenges. The biggest challenge that I have seen in my career is that this way of thinking constrains how we think about behavioral health conditions. And you see this when you hear someone on television who, from our field, who's asked, you know, Dr. So-and-so or Mr. So-and-so, tell us, what do we need in order to better address the mental health needs of the country? And 99 times out of 100, what they will say is, we need more treatment. That is the primary way that we see in helping people. And I want to suggest to you that even though I am a big believer and I have advocated and will continue to advocate for more treatment, that is not the only thing that we need, and that we need to start advocating for things beyond treatment. So what does that look like? So let's deconstruct for a second the black box mental model that we have for how we address mental health conditions. So let me start with just a few conceptual things. So this is, if you thought of this pyramid as the population, about 5% of the population, 5-6% of the population has a severe mental illness, about another 20% has some other diagnosable mental health condition, and about roughly 75% of the population does not have a mental health diagnosis. The way our system currently works is you have to be above that diagnostic threshold of having a mental health disorder in order for us to help you. So if you don't have a diagnosis, as any clinician will tell you who works in healthcare, you're probably not going to get any services. I had a $1.5 billion budget when I was in Philadelphia, managing overseeing the mental health system there. And I'll tell you that we spent about 2% of our budget on things that were not treatment related, that very few resources went for prevention, early intervention, those kinds of things. And we were actually pushing the envelope because most systems, it's probably around 1%. So almost all of our resources are for people above the line. The problem with that is that if you look at the 75% of the people below the line, we know that they have conditions. They may be subclinical conditions, and we're seeing in this COVID crisis that there are people who are experiencing significant stress, that there are people who are experiencing significant psychological distress, but we can't work with them because they don't have a diagnosis. A major problem. Here's the other problem with this, is that many of the people who are in the 75% today will be in the 25% tomorrow. But because we're set up to only deal with people after the fact, we're not using an opportunity now to address people's needs when they can be better addressed. So the first problem is we're only focused on a very small part of the population, and that means that we are by definition only reacting to people's health conditions and the issues that they're struggling with. But here's another thing that we need to be aware of. This is a pie chart of the things that influence our health status. Now, here's another part of the presentation that I would be interactive, and I would say, what do you notice about this? And most people would say very quickly, only 10% of the variance in our health status is attributable to healthcare. In other words, healthcare plays a relatively small part in our health status relative to other things like the environment and our lifestyle, the behaviors. Our behavior, it probably contributes the most to our health status. And you could say that many of these factors are also very important in terms of our mental health as well as our physical health. Yet, we will spend next year or this year over $3 trillion, trillion with a T, dollars on health care, the most narrow part of the pie, something that only accounts for 10% of the pie, while almost ignoring, particularly in behavioral health, all of the other issues that impact on people's mental health status. So that is a problem. And it's, again, not that healthcare isn't important. Absolutely, it's important. We want to have the best healthcare. We want to have the best mental health services. But if we're honest, we know that these other factors are very important, and we're not really paying enough attention to them. One of the ways we talk about those other factors are we frame them as social determinants of health. Things like education and employment and housing. These are things that we know from a lot of experience and from a lot of research have a significant impact on our health status, yet we're not intervening. So I've given you just a couple of sort of conceptual pieces that can help us start to think differently about how we approach mental health, behavioral health issues, moving from that black box that is solely focused on diagnosis in a subset of the population to thinking more broadly about the broader population and other issues outside of the diagnosis that people might have and ways that we can intervene with people. So what would a different paradigm look like? So let's go back to the population paradigm or the population pyramid, and let's organize it a little differently. So rather than organizing it around diagnosed versus not diagnosed, that bifurcation that we have, let's roughly divide the population, the whole population up into three groups. people who have a diagnosis, so that very top part of the pyramid are people who are in that 25%, 26% of folks. But we also know in every community there are people who are at greater risk for developing behavioral health conditions. We know who they are. If I were to ask you, you would tell me very quickly who are the people in our communities who are at greater risk, and people who are relatively healthy. And so our goals would shift from only focusing on the top part of the pyramid, but the top part of the pyramid is still very important. So at the top part of the pyramid, for people who have a diagnosis, our goal as a behavioral health community needs to be, how do we make sure that people have effective and efficient care? That's what we should be advocating for. And I'm going to come back and talk about what I think that means, both in terms of what we need to be doing as a field, but then what are some of the implications of that for what we advocate for. For people who are in that risk category, these are folks like right now with COVID, healthcare workers who we are on the front lines who are experiencing a lot of stress. We know that they are at greater risk for developing other behavioral health conditions. We know that in any community, if you are homeless or if you are experiencing significant financial stressors, that you are going to be at greater risk. We know with some of the more recent incidents that have happened with George Floyd and other people, seeing some of these horrific killings of African Americans, that people in the African American community who are seeing this, who are witnessing this, who identify with these individuals are at greater risk for developing behavioral health conditions. And so the question for us as a field then is, how do we mitigate that risk? Are there ways that we can reduce the risk that people are experiencing? And if we can't reduce the risk, how do we ensure that we are intervening at the earliest possible moment? And then for people who are relatively healthy, they're doing okay. They're one of the lucky folks who, have a job and they can work from home, and they, their kids are okay, and they just don't have the kind of stressors that other people might have in the population. How do we help those folks stay healthy? Are there things that we ought to be doing? And I want to suggest to you that in physical health, we do that. We work at all three of these levels. We do things, for example, for healthy people, or for people, or for strategies to keep people healthy, let's put it that way. We talk about the importance of exercise, of eating right, of sleeping right. Those aren't clinical interventions, but those can go a long way in helping to keep the population healthy and to keep people healthy. And so the question for us as a field is, what would we say if we were asked by people in the community, what can we do to maintain our mental wellness? What can we do to stay psychologically healthy? We ought to have an answer to that, and we ought to be doing that, because that's one strategy for helping to keep the population healthy. So this is a different frame, and so what I want to spend the rest of my time doing is just giving you some examples so that you have a concrete idea of what a whole population approach might look like, and again, what that might mean for our advocacy. So let's start at the top of the pyramid. One of the misnomers about population health is, for some people, it sounds like you're abandoning people who have the most significant issues. Nothing could be further from the truth. We're not saying we should shift our focus from illness to people at risk and healthy people. We're saying, in addition to people who have the most significant conditions, how do we look at these other parts of the population? So it's really important that we have very effective and efficient clinical care. And I want to suggest to you three things that are needed. I'll tell you these things very quickly. First is that we need to make sure that we are using the science and the research that we have available to improve treatment. We know that there is 15, 20-year gap between what we know and what is actually used in practice. The second thing is that we need to individualize treatment based on the things that we know from the literature affect outcomes. We know things like race and ethnicity, your gender, sexual orientation, whether you have a co-occurring condition. We have lots of literature that says these things are really important considerations when we work with people, and we need to make sure that those things are present in our strategies. And then the third thing, in my view, the most important thing from a behavioral health standpoint, is that we need to work from a recovery orientation. That frame is so important in terms of getting the kinds of outcomes that we want. So let me just give you some quick examples. Evidence-based practice. So when I was in Philly, we spent probably close to $2 million every year on helping our provider system integrate evidence-based practices into their work. And we're doing that across a lot. So for some of you who might not know, prior to coming to the American Psychological Association, I was a commissioner for behavioral health in Philadelphia for almost over a decade, for 12 years, and really focused on shifting and changing that system to be more recovery oriented and to improve overall outcomes. So one of the key strategies was infusing and growing the evidence-based footprint in the system. And these are just some of the evidence-based practices that we were doing. But I want to take one example and to illustrate why it's so important to use the science to drive what we do in clinical practice. So one of the people we work with was Aaron Beck, who lives in Philadelphia. And what we were able to do is to take cognitive therapy, cognitive behavioral therapy, infuse it in all kinds of settings that it had historically not been systematically infused into. And one of the areas was these extended acute inpatient beds that we had created when we closed state hospitals. These were people having really, really difficult times, serious mental illnesses, were not getting better in a traditional mental health program, and yet they still needed a very high level of care. Some of these people would have lengths of stay that would last almost a year or maybe even more in an acute setting. So we systematically incorporated recovery-oriented cognitive behavioral therapy on these units around the system. And here are just some of the outcomes. We reduced the length of stay by half. These are beds that were costing the system probably around $600-700 a day. We reduced assaults 60%. We reduced restraints and seclusion, reduced the use of IM medication, and we reduced or increased the number of people that were accepting referrals once they were discharged to ACT teams and continuing care. We saved millions of dollars. We greatly improved the care and the outcomes of people in those programs. And it really shows the importance of using the research, using evidence to improve overall outcomes. Let me give you another example, and this is an example around how we individualize treatment. What you have on the screen are two lines that you see improving over time. This is penetration data. And penetration data is just simply the proportion of people in a program that are in an insurance program that are accessing services. And in this case, this is a proportion of people in the Medicaid program that were accessing behavioral health care services. And what you see is that over time, over the decade of data that is here, that the penetration rate was going up for both children and adults. That is a great thing, right? That we were getting more people into treatment and ensuring that more people had access to services. And this is not shown on the slide, but I can also tell you that as we were doing this, we were also reducing the overall cost per person in the system. So we were increasing the number of people and reducing the overall the per person cost, which gave us more resources to serve more people. But if you disaggregated that data, you get a very different picture. What you see is that the penetration rate for Asians was very low, in the 5% range. For African Americans, it was about half of the penetration rate for whites, and for Hispanics. Hispanics actually have a very high penetration rate, and that was primarily because there were a number of Hispanic providers in the system. So what does this tell us? Number one, it tells us that it is critical that we disaggregate data, from a policy standpoint, we should always advocate for that because we know that race and ethnicity affects outcomes. This data clearly shows that. It shows the importance of having the data. But let me go a step further in showing you what we did as a result of seeing this data. These 3 maps that you see here are maps of Philadelphia. And I'm going to give you the 10-second description of this. These 3 maps show you, 1, where African Americans live in the city, what the utilization patterns are of services in the city, and then where providers were in the city. This was work done by researchers at University of Pennsylvania. So what this essentially says is that one of the things that explains the inequities that we saw, or the differences that we saw between populations, is that the places where African Americans lived were the places where we had lower utilization in the system. And guess what? That mapped right onto the number of providers that we had in those communities. And so what it told us is that part of what explained this was that we didn't have services in those places that these populations lived, and that the solution was, and this is what we did, is to do RFPs in those communities and put more services there. I say that because from a public policy standpoint, we talk a lot about cultural competency. I believe in that. But here's a great example of a structural inequity. We're hearing a lot about structural racism. This is one of the ways that that plays out, is that there's a structural problem within the system that we have to fix. And so part of our strategies have to be to include, 1, understanding how different groups are doing, but then also understanding, are there structural issues that are driving the changes, and then making sure that we're addressing that and how we work with, and how we advocate and work with people. And then finally, I wish I had more time to talk about recovery. I think that using recovery-oriented approaches is probably the most important thing that we can do to improve people's outcomes. And that means working more collaboratively with people instead of hierarchically. It means asking people what it is that they want out of the treatment, their treatment experience, as opposed to us writing out a treatment plan and then putting it in front of them and asking them, telling them what to do. It means that we are thinking about recovery from a more scientific basis. We talked about, when we talked about the black box, that recovery and recovering from a mental illness or a substance use condition is more like diabetes. It's a long-term issue. It's not an acute care issue. And so we want to make sure that we are building into our systems those long-term supports that people need, making sure that people have things like housing and educational supports and supported employment, because we know that those things will improve overall outcome. It's moving beyond treatment and thinking about, how do we help people have the kind of life that they want to have? How do we help support that from a behavioral health standpoint? And then how do we make sure that we have the resources that we need to support that? So shifting to that recovery focus, we know improves outcomes, but we also have to have public policy and financing that supports that. So what about the next part of the pyramid? So those are strategies for people who have a diagnosis, but for people who are at greater risk, what are some things that we can do? And I'm going to give you some examples from our work at the APA, at the American Psychological Association. We know that during this COVID crisis that people were under a tremendous amount of stress who are working in healthcare settings. And we know that those people are at greater risk for developing behavioral health conditions. Now, we could wait until they have a diagnosis and then treat them, or we could try to put into their hands tools that they could use to mitigate the stress that they're experiencing. So that's what we did. In fact, when we talked to many of the nurses and other healthcare professionals, what they said is, you know, we could really benefit from things like support groups and those kinds of things, but a lot of times we don't have time to do that on our shifts. Can you give us something that will help us address the stress or mitigate the stress that we're experiencing during our shifts? And so what we did is we looked at the psychological literature, talked to some of the experts within our association who work in health psychology, identified exercises that people could do based on good, sound psychological research, created these exercises, and you can see on the screen there some of the things that we suggested to people. And then we told them, here's the science behind why this works. And that what that allowed people to do is to not only know what these strategies are, but understand why these things work. So it's one way that we can work with people that is short of having people needing to go to a mental health professional. One of the other things that we did is in the aftermath of the George Floyd killing and the number of protests, what we heard over and over again was just the sheer stress that African-American communities, particularly African-American men, are experiencing. And so we did a number of things to try to reach out to that community. So the idea is this: we know that these folks are experiencing more stress, and the idea was, can we help educate people about how to manage their stress, but also to normalize mental health issues, and can we help people be more willing to reach out for help when they get to that point where they are no longer able to handle the issues that they're dealing with. And so we did a whole number of sessions, webinars, reaching out to African-American men, working with My Brother's Keeper and My Essence Magazine and other organizations that had connections to those communities. And what we were doing is educating people, reframing the issue. So we didn't talk about mental illness, we talked about mental wellness and what people needed to do for their mental wellness. And we were exposing a whole population which historically has not sought out mental health services as a group by and large, but really trying to normalize. So another strategy here is, so the first strategy was, can we give people tools? The next strategy here is, part of what we have to do is to reach out to communities, help to educate them, help to normalize these issues. And then one last example with rural and frontier communities, made a big commitment to our frontier communities, people who are on farms and living in places like Montana and these states where there are very few mental health practitioners. So when we started doing this work, one of the things that many of the people in farm community told us, for example, is that farmers are under a lot of stress. Many people don't know, for example, that we are experiencing in our nation right now a farm crisis, the likes of which we haven't seen for decades. Most people don't know that. Most people don't know that the suicide rate for farmers is much greater than the general population. But when we talk to people, what many of the people from the community said is like, a lot of times we're out on our tractors and we're listening to the radio. It would be really helpful if you all could create some tools or some podcasts that we could listen to while we're out on the farm. They said to us, a lot of the farmers are calling hotlines about saving their farms and some of the challenges they're facing. And what the workers who are doing that work would say is that a lot of times many of these people were in psychological distress and they actually needed mental health interventions. And so we started working with some of those individuals to help them better address those needs when people called up. So these are just some of the examples of, again, this isn't treatment, but this is putting information, helping the people who are helping the people, advocating for things like telehealth that give people access. Those are all really important public policy strategies that can reach people before they necessarily are in distress or in crisis. Means we need to work on the crisis things, but if we can reach people before that, mitigate the stress, we want to do that. And then finally, just a few examples of how do we help keep people healthy. I'm going to use an example from Philly again. One of the things we did is we rebranded our work around the idea of Healthy Minds Philly. You can see that this doesn't look like a government website, mainly because we wanted people to actually use it. If it looked like, come here to treat your psychopathology, probably not so much. Come here to help improve your mental wellness, probably a little more inviting. And so we rebranded our work around this idea of Healthy Mind Philly, did things like like mental health screenings, those kinds of things. I want to give this example that just recently happened at the APA convention, because I think it's another great example of how we in our field have to reframe our work. This is the gentleman that you see there is a linebacker from the New Orleans Saints, and a sports psychologist, Dr. Nayaka Nilamti, and Demario Davis is linebacker. And they had a wonderful session where they talked about, and he talked about specifically what he did to optimize his performance on the field. And he talked about the importance of proactively addressing his mental health challenges. He talked about things like going to a marriage therapist with his wife once a year as a check-in. Talked about seeing sports psychologists, not when he was in crisis, but just to check in and to make sure that he was mentally as strong as he could, and how that gave him an edge on the field. Wonderful presentation, because he's talking to men, many of whom be very reluctant to go to a therapist, but because of who he is and the way he framed it, it's going to open that possibility up to many more people. The only point I'm making here is that as we're thinking about how we reach populations, we need to think about how do we make sure that we have the resources to do those things that are beyond treatment, those things that are reaching people that we would not ordinarily reach. How do we use resources to help normalize mental health issues? And then this last example of something that all mental health professionals, I think, ought to increasingly do, and that is to be a technical assistant to other parts of our community. And so these are just, again, examples, talking, within the national PTA to parents and to teachers about things that they can do to promote resilience in children. And while that can go a long way, these teachers are reaching tens of thousands of children around the country, and we can give them a few tips, a few strategies that can improve the mental health of the children that they're working with, go a long way. Similarly, working with mayors and governors and their staffs around how do they message in such a way that they highlight the importance of mental health, but also how do they communicate in such a way that they reduce anxiety. And there's a whole science around that. And so we shared with them, here's the science around risk communication. And then other strategies in terms of helping other people do their work more effectively and using science-based strategies in their work. So let me just end with some of the implications for all of this for what we advocate for and what we ought to be doing as a field. One is we absolutely have to start working upstream, moving away from waiting until people have a diagnosis, but looking at all of the other points along the continuum when we can intervene with people. It's important to think about how social determinants can help improve outcomes. It's not that we are going to, as a field, become housing experts, but we absolutely need to be partnering with people who are and making sure that those services are available to people who have behavioral health conditions. That is a policy issue, and there are a lot of barriers to that right now. We need to embed services in the places that people go. So rather than asking people to come to the black box, what if we were to take mental health professionals and embed them in the places that people actually go? And there's some great examples of that we can potentially talk about. Empowering people to take ownership. We call it health activation. It's talking to men about what they can do, or talking to teachers and others about what they can do to help empower the people that they're working with. How do we work with people who are healthy, not just waiting for people to have illness? Enlisting others to build mental health literacy so that people have a basic understanding of mental health. And then how do we work not only at the individual level, but there's some things that we can do at more of a community level. The work that we were doing with mayors, for example, was really about, you're in a position to say and to give messages that can have an impact on a broad community level, not just, again, asking your people to go to see a mental health professional, but what are some of the other things that we can do? And then most importantly, from my standpoint, is to reframe mental health from this issue of this is a group of people that we're trying to help, to seeing mental health as something that affects all of us, and that our strategy as a nation needs to be to address mental health issues across the continuum of need. That is the only way that I believe that we'll be able to address the issues that we're seeing being brought up by COVID. We cannot do a one person at a time, one-on-one strategy given the magnitude of the needs. We have to do that, but we also have to think about the broader kinds of interventions, the broader strategies that we can do to address people's needs. And in doing that, we will also address some of the long-term structural issues that we've had in our system. So with that, I want to thank you for this opportunity. And
hi, everybody, and thank you, Dr. Evans. It's our great privilege to have you here with us today. Arthur, while we wait for people to type in their questions in the chat box, and please, I'm inviting you to do so right now, let me start with a question. When you were in Philadelphia, you embedded peers in just about every part of the system. Can you talk a little bit about that, please?
Sure, and thank you, Debbie, for inviting me to be here and having an opportunity to talk to folks. Yeah, I think, and I think I don't know if I said this during my presentation, but my view is that having the voice of people with lived experience is essential. And I didn't just see peers as sort of a service that we were trying to incorporate into the system. What I saw is the voice of people with lived experience. And so I made sure that there were people on my executive team who had lived experience. There were people at all levels of management. There were people throughout my organization. And in addition to that, that people with lived experience were actually in a position of providing services in the case of peer specialists. And what I found and what we found both in my work in Philadelphia and in my work in Connecticut is how critical that is, because there are certain things that people who might have more formal training can do and can do well, but there are other things that people with lived experience are much more capable of doing. For example, keeping people connected to services. In my experience is that people with lived experience are really good at that, and programs that don't incorporate people with that skill set are going to miss out. Keeping people engaged, but also helping people with, I always think of recovery as this walk, and that we're walking with people on this journey of recovery. And people, it's not just about treating people's symptoms, it's about how do you help people live. And often people with lived experience, peers, are really good at helping people with that journey and walking. So I just think that peers are critical to an effective system. And I think in the absence of having people with lived experience working in the system in that way, I think we're not going to get the kind of outcomes that we want as a system, and people aren't going to get the kind of care that they need.
Thank you so much, Dr. Evans. We are waiting for those questions and answers, but I'm always happy to ask you more questions. And one of the things that was quite remarkable in Philadelphia, in fact, when I came from Philadelphia under the system that you ran, and when I came to Mental Health America and all throughout Pennsylvania, my fellow advocates used to tease me and call me the queen of upstream. And certainly that's... yes. And that's Mental Health America's tune, is that we know that the earlier that we get in, the better the outcomes. And one of the things that, even though it was difficult, and it's difficult all over the country, was to focus on kids and families. Would you talk a little bit about kids, families, and why it's so important that when we talk early, we not only talk about early in the process and before, as we say at Mental Health America's for, but early in the process with kids and helping their families?
Yeah, sure. So I think, and it's really important to make both of those distinctions, that upstreaming is both intervening earlier in the process for adults, but it's also intervening developmentally earlier in the process. We know that a lot of people experience significant trauma early in life, and that trauma, if untreated, undetected, can significantly change their life course. One of the things we did in Philadelphia, for example, was to screen children for traumatic stress in primary care settings, the settings that they were going to, many of the parents felt comfortable with. And what we found is that we were finding about 20-25% of people children had experienced trauma that really needed to be treated, and that there needed to be some kind of intervention. So I think any of us who are working in the system ought to be consistently thinking about, how do we identify issues that children might be experiencing? How do we not only identify, but then how do we intervene? And in the case of the work that we were doing with children and screening them for trauma, we also created a network of evidence-based trauma programs, TFCBT in particular, and we're able to then connect them to those services. So it's about a mindset of understanding how important those interventions are. It's about building infrastructure within our systems so that once we identify those issues, that we are providing the best possible services. But it's also doing some of the things I talked about in my presentation, which is how do we help educate, provide technical assistance to people who are working with children and people who are in child serving systems. I was commissioner for our child welfare system for about 18 months in Philadelphia, in addition to doing the mental health work. And it was really clear, if you work in child welfare, you really need to have a mental health background, or you certainly need to have the very strong connections. Same thing with juvenile justice, same thing with educational systems. So we have to be thinking about that and then integrating and embedding services in those systems, but also providing technical assistance to people who provide those kinds of services.
Thank you so much for that really in-depth answer. We've got a bunch of questions coming, and I'm going to kind of combine them in the sake of time. So let me kind of run through this a little bit. Did you have any resistance to changing from a frame of mental illness to mental illness? And related, we have a question from Connecticut about where social determinants are coming into the conversations with legislators, and how do we help look at that? And also, where you see those social determinants of health issues coming up, how does racism play into that?
Sure. So a lot of questions there. So let me just say, absolutely, anytime you try to change a paradigm, you're going to get resistance. And, we got resistance when I was in Connecticut. We got resistance when I was in Philadelphia. I'm sure we're going to get resistance in my role in APA as we talk about some of these concepts. But I think that, I used to tell people, it was like, people would ask me, well, how were you all able to, really change the paradigm? And I gave them this example from Saturday Night Live. There was an old skit where no matter what you ordered in this restaurant, they would always say, cheeseburger, cheeseburger, Pepsi, Pepsi. So some of us are old enough to remember that skit. And a lot of this is about, cheeseburger, cheeseburger, Pepsi, Pepsi. In our case, it was recovery, resilience, and we just kept at that. And I think what happened, this is why people having lived experience are so important. It's not just me saying these things are important, but when people stand up and say, here's what helped me, it was that people work with me differently than they had worked with me historically. That makes all of the difference. And so I would encourage any of you who are really working on changing your system and trying to make these shifts to keep at it, but also enlist the help of people with lived experience, because they can be great spokespeople for why these things are important. In terms of social determinants, it's really, I think it's critical. I showed that pie chart of only 10% of our health status being attributable to health care. that we have to start thinking about these other influences. And we don't have to be experts in all of these areas. What we have to do is incorporate these things into the way we think about how we help people, and then be willing to advocate with our colleagues in other areas, in housing, in workforce development, and saying we need to partner, because if we're going to be effective and get the outcomes that we want from a mental health standpoint, we can't do that if people don't have a way of gaining employment or gaining education or gaining housing, that we systematically incorporate those things. And then finally, on the racism issue, we just did our annual convention. We had some fantastic speakers. We're going to be putting some of those sessions out, but one of the themes in the work that a lot of these experts talked about is the importance of understanding the science of racism and understanding that people experience what's called race-based traumatic stress. That people who communities of color, members of communities of color, are experiencing all of the time these what are sometimes called microaggressions, but sometimes really significant stressors related to racism that they may be experiencing, and that has an impact on people's mental health. We've not talked enough about that in our field, and I think we have to recognize that that is real, that people experience those. Most times, most people of color, when they're in treatment, people don't talk about issues of race. I would really encourage people to systematically do that. Whenever I work with women in my clinical practice, I would always raise the issue of sexism, because people may not feel comfortable saying that, but I wanted to signal to them that it was okay and that was a legitimate area for us to talk about. Similarly, people need to know that their experiences around racism are a legitimate issue, because it is impacting on their mental health.
Thank you so much. We wish we had so much more time with you, but we have one more question. Can you talk about some of the financial barriers and the systemic barriers and overcome them really quickly, because we have about 1 minute?
Sure. I think one of the things that we did in our field, and we continue to do, is to Medicaidize everything, right? And we do that because it's a way of increasing the dollars that come into the state, because the state is paying half of the bill, the federal government is paying the other half, roughly. And so one way of expanding services was to get as many things into the Medicaid program as possible. The long-term problem with that is that the only thing that Medicaid will pay for is treatment. And so in a lot of ways, we've abandoned those things outside of treatment, in part because of the way we have financed most of our system. What I'm saying is we have to really strongly advocate, not only for treatment, but for systems administrators and programs to have resources to do those things outside of treatment. And unless we start to making that a priority, we're going to get more of what we've always had. So I really hope that we can do that. We can, as you said, Debbie, get upstream. We can't do upstream if we don't have financing to support it. Now's the time for us to do that, given this pandemic and the great needs that we're seeing.
Thank you so much, Arthur. I know that if we were in the room with you, we'd give you a great big round of applause, and I would give you a big hug. So thank you, and we're going to move on to our next speaker, Colleen Reilly.
Okay.
And I'm going to introduce her. Thank you again.
Take care. Bye-bye.
Bye, Arthur.
Bye-bye.
Hi, everybody. I would like to introduce Dr. Willie Garrett, who is a licensed psychologist and certified employee assistance professional with over 30 years of broad behavioral health service in both urban and rural settings. He currently works in private practice and specializes in all age groups, from children as young as age 5 to senior citizens. In addition, Dr. Garrett offers trauma recovery, workplace violence, critical incidents, cultural competence, adoption and transracial adoption, mental health legislative advocacy, rural mental health, and general mental health services.
She conducted the landscape analysis that produced the Mind the Gap report on perinatal mental health disorders. It has been my honor to bring the MHA perspective to this project. Colleen today is going to talk about the Mind the Gap findings and its calls to action. Colleen?
Thank you. Welcome, everyone. And thank you, Debbie, and our partners at Mental Health America for this opportunity to share the Mind the Gap initiative. It's a national strategy to ensure perinatal mental health is a national priority. So on behalf of Postpartum Support International, who is leading the Mind the Gap initiative, as Debbie said, I'm Colleen Reilly, and I'm the president of the Reilly Group, and I serve as the director of the Mind the Gap initiative. Also, I want to give a shout out to my friends from the Mental Health America Network. As Debbie mentioned, I'm a former MHAer, and I have had the honor of working with board members, staff leadership, and many chapters, and I'm always inspired by the excellent work you do. So today's presentation, as Debbie said, is going to focus on 3 tasks. We want to give you an overview of the Mind the Gap Collective Impact Initiative, discuss how the initiative advances perinatal mental health through its 2020 and 2021 policy and project priorities, and outline how you can join us and advocate to ensure perinatal mental health is a national priority. So as I mentioned, Mind the Gap is a collective impact initiative. It's really a national coalition, and the goal is to implement this national plan in partnership with Mental Health America and others to improve the mental health and the well-being of pregnant and postpartum women and families, and thereby their babies' development. So the initiative stands for advancing perinatal mental health awareness, research, access to education, prevention, screening, diagnosis, treatment, and support services. Postpartum Support International is leading the Mind the Gap initiative in partnership with Mental Health America and about 35 other leading professional and advocacy organizations. PSI is known for its mission to promote awareness, prevention, and treatment of mental health issues related to childbearing in every country worldwide. They are the largest organization devoted to perinatal mental health. And when we say perinatal mental health, what we're really referring to is a woman's mental health during pregnancy and in the first 12 months after delivery, thus postpartum. But it also encompasses the impact her mental health has on the infant and family. A range of mental health disorders like anxiety and depression can affect mothers during this period, and without treatment and support, can have a negative impact and sometimes long-lasting impact on the physical and emotional development of infants and children, as well as fathers and partners. Next slide. So we're going to the next slide, thank you. Naming the initiative Mind the Gap was intentional. So there are just too many gaps in our awareness of its impact, research, the availability of screening and access to care and treatment. And these gaps have only been exacerbated during COVID-19, as you can imagine, right? Where pregnant women's opportunities for in-person doctor visits are very limited, increasing fear and anxiety. Dads and partners' ability to be present at delivery are limited, if not completely restricted, due to COVID-19 precautions. Also, many pregnant and postpartum women are working, right? So they're still continuing to work while taking on more childcare. And how about homeschooling duties? Her work may be putting her at risk of coronavirus exposure if she is on the front lines of care or serves as an essential worker. We're hearing from women that they are losing their jobs, facing unemployment and financial strain. Calls to PSI, Postpartum Support International's line, have increased tenfold, and support groups have quadrupled over this time period. So we'd like to share a couple of important facts on the next slide, please. Thank you. About the gaps in perinatal mental health, right? So perinatal mental health, mood and anxiety disorders are the #1 complication of birth. This is not generally known. the CDC has reported untreated mental health conditions were the second leading cause of death that occurred 43 days to 1 year at the end of pregnancy. 50% of women who even get a diagnosis do not get treatment. The research also showed that the economic burden of untreated perinatal mental health disorders is really costly, estimated at $14.2 billion for all live births, and this was in 2017. Another important point of research to share, and this really did inform the Mind the Gap strategic plan and report, is the analysis on the level of federal funding for perinatal mental health research. This slide shows federal funding from the National Institute of Mental Health and CDC, the Centers for Disease Control and Prevention. And you can see the funding for perinatal mental health in 2017 was far less than other conditions that affect women, such as heart disease, breast cancer, and lupus. Heart disease, which affects 1 out of 5 women, received $3.3 billion. Breast cancer affects 1 out of 8 women and received $1.4 billion. And lupus affects 1 out of 200 women received $197 million. And there we have perinatal mental health, right? Which has a similar prevalence to breast cancer and heart disease, receiving only $54 million. That's in the blue circle. Why is it that you might ask, right? These other health conditions are critically important to do research on, but these other diseases and disease areas and groups that they represent, they've had a concentrated, intentional focus on building awareness and federal advocacy for these critical issues. We must do the same. Federal funding does not match the prevalence or the crisis of perinatal mental health. Next slide, please. Thank you. So perinatal mental health gaps, right? They're even wider among our Black and brown women, our sisters. African American and Hispanic women have the highest prevalence of perinatal mental health depression, primarily attributed to a lack of social support, access to care, and a history of trauma and prior depression. Racial disparities are further compounded by a lack of proximity to services, a lack of insurance coverage, as we well know, and the stigma that accompanies mental health, and a mistrust of mental health professionals. For example, 4 in 10 low-income African American mothers do not access postpartum visits, thus they don't receive the care and support for postpartum depression and other challenges they're facing. You'll see this quote from one of our partners, Linda Blount, and she's with the Black Women's Health Imperative. And I think her quote really sums it up quite well, that generations of racial and gender discrimination have taken an extreme toll on Black women's maternal health. And the Mind the Gap, we're looking to the Mind the Gap to be a forum to address these issues. On the next slide, one other factor to consider is that perinatal mental health is really about prevention, as well as intervention. Unaddressed and untreated perinatal mental health impacts infant and children, and research studies have shown that women with untreated depression during pregnancy are at risk of developing severe postpartum depression and suicidality, and of delivering premature or low birth weight babies. Depression during pregnancy can result in alterations to the DNA of the developing fetus. Untreated postpartum depression hinders infant attachment and bonding, right? Which can lead to developmental disorders that last into adolescence and beyond. Next slide, please. One moment here. So given all this, what can we do to address perinatal mental health? So let's take a look. So based on, Debbie had referred to the fact that we did a landscape analysis on perinatal mental health. And so you saw some of the research associated with that. So we took that research and that landscape analysis and we brought it to a convening of about 30 organizations. And through their guidance, these leading organizations helped us develop a strategic plan. And we convened last September, and the organizations really represented the cross-section of stakeholders really involved in perinatal mental health, and it's across the board. So it's infant and children's health, maternal health, maternal mental health organizations, public health organizations, women's health, government, academia, and healthcare systems. And we're so grateful that we are working with these partners because they're an amazing group that bring their own expertise to the issue. And in fact, we were really reliant on Mental Health America and its policies and recommendations related to perinatal mental health to guide our work. So in the next slide, what you see here is essentially an overview. In the next couple of slides, you'll see an overview of the strategic report. So this was the result of the landscape analysis and then working with our partners who came up with guiding principles, which you will see at the top, priorities, and then specific actions, which we're going to detail in the next few slides. So the first thing that's really important to keep in mind is the intentionality of being guided by principles. So Mind the Gap is guided by the recognition that we need to increase public and private sector funding to improve outcomes. We saw the lack of research dollars in comparison to other critical health conditions with equal or lower prevalence rates. We need to work together to increase government program funding for perinatal mental health state grants. And we can work together to engage private sector and philanthropy for mental health. We can collaborate to extend Medicaid funding in public insurance from stopping at 60 days postpartum to extending that to a year. We are also guided by the principle that we must work in partnership, right? So support and work of others through advocacy, education, and networking. And there are several partners who are really taking the legislative lead on many policies and legislation that are particularly important for perinatal mental health, such as extending Medicaid coverage. And importantly, Mind the Gap is guided by ensuring that when we advocate for research and policy and programs and practices, that they are culturally relevant and meet the needs of Black and Brown women and families who are at greater risk and have poorer access. So just this week, PSI and Mind the Gap joined the 2020 Black Maternal Health Caucus Stakeholder Summit that provided an analysis on the Momnibus 2020 legislative package and promotion of Black maternal health in 2020 and beyond. This is important work where we can join with other coalitions to do that. So in this next slide, so moving from the guiding principles, Mind the Gap work is focused on 5 key priority areas, as noted here. Again, these are very much detailed in the report, which we're going to send to you following this presentation. And they focus on raising public awareness, ensuring perinatal mental health screening is universal and routinely provided, and includes diagnosis and treatment and access to care. We also are focused on, as a priority, access and coverage in public and private sector insurance to the treatment care that really help women suffering from mental health disorders. We need to do a better job in workforce development and providing education and training, not only to frontline workers, but peer support specialists and others who can really be a support to moms and families. And we also need to focus on promoting clinical and prevention research on perinatal mental health. In this slide, you can see the guiding principles at the top, right? And then the next priorities with specific aligned actions. So this gets to the work where we're going to really deliver on these guiding principles and these priorities. These are the actions, or the how we will ensure better outcomes. So at the bottom of the screen, you'll see, for example, as a collective, we want to increase funding For HRSA's, the Health Resources and Service Administration's Maternal Depression and Related Behavioral Health Disorders program. It now funds 7 states, but a whopping 39 states applied for this program. The need is there, and the funding is not matching the crisis. This grant program is one of the most, if not only direct program that is focused on increasing maternal mental health education, training, screening, access to treatment, and support services. It receives $5 million annually, and we can do so much better, and we must do better. Another action is ensuring that perinatal mental health is a critical component in maternal health, mental health, and women's health policies, right? So it's really a part of the work that we do in mental health and the work that we do in women's health. So we want to make sure that it's at the table, it's part of the dialogue, and it's part of the policies and legislation at the federal and state level. You can help us as you consider policies and legislation in your own states and communities. And another key action is working to have perinatal mental health a priority in healthcare systems and birthing hospitals. Currently, there are several models of quality care, and we need to see that they become more standardized throughout other health systems. And here we see the 2 of the remaining 5 priorities with corresponding actions. For example, you will see the lower left box action item is to advocate for increased federal funding to focus on clinical and prevention research and the public health impact of perinatal mental health. Currently, there is discussion and compromise hopefully happening between the congressional package and the Senate package. And one of the asks is for $100 million for NIMH research, which we hope survives in the final package. And we want to see some of those dollars go to perinatal mental health research. So remember the previous slide showing perinatal mental health receives $54 million versus $2 to $3 billion. We can do better in terms of our advocacy around increasing federal funding. So these actions are the roadmap for the work we will do in partnership with you, with Mental Health America, and with other national organizations. And in this final overview of our strategic plan, Mind the Gap is going to be implementing some key projects over the coming years. And this is another opportunity for us to work with you and your organization to participate. And we really welcome your participation. So you'll see in the red or orange circle up at the top, we're convening state and regional meetings to engage a broad cross-section of stakeholders to help build awareness of the critical issues at stake, promote policies and model programs and best practices for perinatal mental health and healthcare systems. We want to galvanize community engagement and support people's efforts in driving forward and improving outcomes for women. In the blue circle, you will see we'll be holding regular conference calls and webinars on policy, legislation, and actions we can take as a coalition and support others in their leadership to increase federal funding, improve access to screening and treatment and services, and feature model programs. Up on the left corner in the yellow circle is our third project, which is to advance a national campaign with private and public sector support to raise awareness of postpartum depression and amplify the voices of women and families with lived experience. So we invite you to join us, and here's the next step to be involved. We hope that you can read and share the Mind the Gap National Report with your colleagues and spread the word about this public health crisis and what we can all do together. Participate in our state meetings and other advocacy opportunities, which we can share with you as they arise. And importantly, we would love for you to sign the pledge. The Mind the Gap pledge, which we hope you will sign and we'll send you a link to, really says that we support moms and families' health and well-being. We believe that perinatal mental health is a major public health issue, deserving national recognition for the impact it has on America's mothers, babies, dads, partners, and families. It illustrates the goals of Mind the Gap and our collective stance. We heartily invite you to sign the pledge via the web link on the screen, and we'll also send it to you. And as part of the pledge, it asks for a specific message about why you or your organization think improving perinatal mental health outcomes is important. We hope that you will send us a picture along with your signing the pledge so we can post your picture and a quote on the Mind the Gap dedicated pledge page. We are building and growing a digital mosaic of pictures of those who have signed the pledge. And also, this will be our way for us to connect with you, to provide opportunities to participate in advocacy, state, and coalition meetings. I want to thank you so much to Mental Health America, to Debbie and her friendship and collegiality, and thank you for your time and our sharing this presentation. We really look forward to working together and the great work to come. Thank you very much.
Colleen, thank you so much for being with us today to Questions Live. We invite folks to put questions in the chat box and we will ask Colleen to answer them. And we have one waiting for you, Colleen. So the question involves whether or not the things in Mind the Gap and that are addressed and that are part of moving forward on advocacy, are there things that address women who've gone through a miscarriage or a stillbirth?
Well, first of all, let me say thank you again for allowing me to be with you today and all of the folks that are part of this policy program. And I think that's a really wonderful question. And it's very, very sad obviously for anyone to lose a child, miscarriage or otherwise. And that can result obviously in stress, anxiety, depression, postpartum blues, a whole range of things. And I think Postpartum Support International in particular is there to serve women and families as they go through pregnancy and postpartum. So it does address it in the sense of, as a Mind the Gap initiative, we want to increase supports and services for all women, pregnant and postpartum. And that would include those unfortunate enough to have to go through a miscarriage.
Thank you, Colleen. We're waiting for some more questions to come in, but I have one in the meantime. You touched on just very, very briefly about the need to expand Medicaid coverage for moms. Would you elaborate a little bit more on that? Because we know that moms and babies really are a unit.
Yeah, so thank you for that question, Debbie. And, Medicaid expansion or extension, as it's called, is critically important to women. And in 7 states, I think it's about 7 states right now, they end postpartum coverage at 60 days, right? So this knocks women off during a period of time when they may be just starting to experience depression, anxiety, or a whole range of perinatal mental health mood disorders. So what we want to see is Medicaid extended past 60 days to a full year postpartum in those states. And also what's going on because of COVID-19 is that many of those states have extended Medicaid coverage. And so what we're looking at now are policies to continue. I think this is a really important opportunity to really be on the side of advocating for those extensions, because it's not only helping women, but it's also helping babies and infants and families along the way.
Thank you, Colleen. We have a question from Texas where our questioner says that in Texas, the mother is cut off of Medicaid the minute the child is born. Now, that must be the exception because my understanding is that it's 60 days. In some places, it's 6 months. And what we're hoping for and what we're advocating for is for a full year of coverage for mom as well.
Right. Well, hello, Texas. And thank you for the question. And I'm not familiar with that policy in particular. but it seems even more obviously restrictive, unnecessary, and something that needs to change. And hopefully there's something going on with COVID-19 where Texas has extended Medicaid. I'm not sure about that, but I think that's something for us to look into and to support your efforts to extend Medicaid coverage.
That's a really good point, Colleen. One of the things that Mental Health America and, of course, all our partners, that we talk about expanding Medicaid in general for the states that haven't done so. So, as a matter of advocacy, we ask that as states continue to expand Medicaid, and congratulations to Oklahoma and that have just done so, that they look to expanding the coverage for moms for that full year. We've got a question here. No, I don't have a question here. I'm looking for some more questions, but I would like to talk a little bit about how do we do specific outreach to color and get the moms to be engaged in their mental health as they go along through the process of prenatal and perinatal.
Thank you, Debbie, for the question. I think I got most of that question, and it's about engaging mothers, but equally, I think, families, partners, and fathers in the advocacy work. And I think women have a lot on their plate, right? Immediately thereafter, delivering a baby, maybe having other children in the family, dealing with their own mental health conditions. And as I mentioned, Postpartum Support International is a wonderful organization providing free, no-cost services and supports in Spanish and English to women and families via text, via online support groups. And I think through the process of healing and recovery, being able to engage them in telling their story of lived experience and really being able to come alongside the work that we do, because they are essential to the work that we do, in sharing their stories of recovery and hope and help, and really helping raise awareness about the unaddressed and untreated situation of perinatal mental health.
Thank you, Colleen. We have a question that I'm going to take a guess as to its full meaning. It was asking about how the Mind the Gap report and the calls to action will address the zombie years. And I'm assuming the zombie years have to do with the fact that moms don't sleep very much. And they're kind of going through not just that immediate birth period, but for a long while.
I think in many of the policy actions that we're talking about really do relate. And I know sometimes policy can be, at the 60,000 foot level, but if we're talking about policies that extend Medicaid coverage, policies that increase workforce training around perinatal mental health, we're talking about supporting frontline workers in their support for moms and their knowledge about the care and support services that they do need when they're going through the zombie, and anybody would be going through that, dealing with a newborn baby and not getting the sleep that they need during this difficult time, and really needing additional support services. So I think it's a holistic approach to think about the mental health and well-being of moms and families. And to really remind her of the importance of taking care of herself. And I think many of the organizations that we work with, and most certainly Postpartum Support International, is really educational and supportive of women taking care of themselves during these kind of tough. Yeah.
Yeah, I'm afraid that we have to end here, and we're going to introduce our colleague, Shannah Mulvihill.
Hi, everybody. I would like to introduce Dr. Willie Garrett. who is a licensed psychologist and certified employee assistance professional with over 30 years of broad behavioral health service in both urban and rural settings. He currently works in private practice and specializes in all age groups from children as young as age 5 to senior citizens. In addition, Dr. Garrett offers trauma recovery, workplace violence, critical incidents, cultural competence, adoption and transracial adoption, mental health legislative advocacy, rural mental health, and general mental health services. He has held positions as the director of several large multidisciplinary integrated care clinics and served on the boards of Capella University, Adoptive Families of America, and the Employee Assistance Society of North America. Dr. Garrett is the president of the Minnesota Association of Black Psychologists and the Minnesota Psychological Association. And I've had the pleasure of working with Dr. Garrett recently on some efforts to support mental health healthcare professionals and other essential personnel. And it's been a real pleasure to get to know him and work with him in the last several months. And with that, I will turn it over to Dr. Garrett.
Thank you, Shannah, and welcome everyone. Today, I'm going to talk about policing, and in particular, policing around the events that happened in Minneapolis around the George Floyd murder. I'm going to talk about policing from the perspective of once being an employee assistance professional working with law enforcement, where I saw police officers who were involved in critical incidents, anything from shootouts to having a baby die in front of them, and worked with police officers and other law enforcement on general mental health issues as well. The other perspective that I'm going to talk about in terms of policing has to do with me being an African-American man and being a person from poverty, and growing up in Philadelphia, Pennsylvania, and being a teenager there, living in a community of 1 million Black people, and my experiences with the police as well, things such as being stopped by the police twice while I'm walking home from school. And I had like a mile walk from my high school to my house. And there were days when I would get stopped twice by the police, searched, shoved around, called names, and then they would send me on my way again when they couldn't find anything on me. So I'm talking about it from those perspectives. But in general, policing has been an issue for a long, long time, not just recently. It may be recent for mainstream America, but being a person of color, I know that throughout my life there have been policing issues, and from a historical perspective, there have been policing problems from the very beginning. When you think about back in the 1800s, when the police were used to control and manage not only people of color and poor white people, but they were also used to catch runaway slaves. And so their job has always been sort of not just about law enforcement, but used as a force to manage and control the population. We then look at other things like during the Depression, where the police were used to enforce the rights or at least the desires of wealthy people, where a lot of poor white people lost their land. The police came and kicked them off their land. And we had people roaming the country who were arrested for like vagrancy and any charge that the officers thought of at the time. Then we head into the civil rights era, which was a time when we had the first video of police action, and we saw the police beating civil rights workers. Recently, we had, oh man, I'm sorry, I forgot his name. He's an African American man who just died. But anyway, we had police beating people, such as what happened during the Edmund Pettus Bridge, when the civil rights workers were walking across the bridge and the police attacked and beat them. We then go on to 30 years ago when Rodney King event happened where he was beaten by the police, and we saw that on video, and it resulted in huge riots. And so this is all not new. It's not new at all. Even here in the Twin Cities, we a few years back saw the Philando Castile shooting with the police, and that was on video as well. Now, from my perspective, from what I have seen of police officers and policing, the vast majority of the police officers that I have met and worked with as clients and both professionally have been good, decent people. They haven't been criminals. Most of them have never taken their guns out. They have wanted to do the right thing and obey the law. And so I think it's unfair to blame all police and all policing on what happened. It seems like there's a small group of active police officers who are predatory and violent. And I can understand that from the perspective of being a Black man, because the vast majority of Black men are law-abiding citizens. We're law-abiding citizens, but our image or brand in America is that we are criminals and drug addicts and that kind of thing, and it's not true. And so I can understand the perspective of the police and it not being true that they are all bad guys. But over time, policing has changed. It's changed from law enforcement to expanded out into social services, where they are handling medical emergencies, mental health issues, children who run away, drug overdoses, and domestic violence situations as well. And it's kind of gotten away from just policing and law enforcement. And I think that's a lot to ask police officers to do. Now, as a police officer, they also have problems and issues. They are repeatedly exposed to traumatic events. There are many officers who have trauma-related problems because they are exposed to events repeatedly quite often. And so police officers themselves have high rates of emotional problems and issues as well. Things like domestic violence, there's a high rate for police officers. Mental health problems, very high rate. And then there's the issue of suicide, where the police have a disproportionately high rate of suicide, often with their own firearm. So we have these officers who are under stress, who are struggling with their own trauma issues and putting them into high risk stress situations. Then we have a situation where we have the militarization of the police, where excess or old military weapons have been passed on to the police department. And this has created somewhat like an army kind of mentality of us and them, of we have the power and control. And as a social scientist and psychologist, I know that whenever you have a weapon around a person, it stimulates and elicits aggression from them. And when you have the police uh, uh, coming from a militarism kind of standpoint, then you're more likely to have aggressive behavior from them. In addition to that, there's the issue of the civilian population becoming more militarized as well. President George Bush, he did not reinstate the ban on assault rifles. And so what happened was that the civilian population was then able to acquire military weapons. And so the police then were put in a different position. Here they are facing military weapons as well as having weapons as their own. It's almost like a warlike kind of situation and mentality. And this is what we saw. This sort of all came together in Minneapolis as an example, because I know of young Black men who over 30 years ago were telling me about the Minneapolis police, how the police were predatory, how they were grabbing young men and detaining them, searching them, and finding something that they could arrest them for, anything from an old warrant or small amounts of drugs that were on them. And so you'd have a young man who did not commit a violent offense, who would then end up going to jail and possibly to prison. And this is what we see today across the country, is that there's a disproportionate number of people of color in prison, but also most of them are there for non-violent offenses. And this is part of what happened in Minneapolis. The George Floyd murder was really just a straw that broke the camel's back. And people reacted to it, not just in Minneapolis, but around the United States and around the world. And as a psychologist, I know that policing has to change. We have to get back to the police just being involved with law enforcement, but we also have to see policing and law enforcement as a social issue and as a public health issue, that things like education can do a lot to reduce crime. And we see that with statistics already. We know that children who get early childhood education have higher rates of everything that's positive compared to their peers. I mean, they graduate high school at higher rates, they go to college, they tend to get married more, they generally don't commit crimes. So education is a big issue. We need to put more money into education. We have to encourage and support more cultural activities, because a culture is more than just celebrations. It is a way of thinking and making sense of the world. And a culture and a family does a better job of managing behavior than policing does. And so we have to do things to support families. And one of the big ones is housing. With stable housing, you'll find that you'll have stable families. You're more likely to have stable families, and those families will influence the behavior of their family members. So in addition to these social science needs, there needs to be different forms of policing, and we're headed in that direction with de-escalation being required. We need to change the rules for police officers and require de-escalation. We have to ban chokeholds and other restrictive types of acts from police. We have to keep officers having cameras on. We have to have officers take some sort of action to retreat before shooting, and to not shoot people who are running away, who don't pose a danger to society, and have the police not pull over people for having a tail light out. Like Philando Castile was stopped 50 times in the 2 years before he was killed. He was stopped 50 times by the police when he was in his car, which is unbelievable. And so we need a combination of a lot of things to change policing. We need to support the police. We need to engage them. We need to have communities involved in policing and the heads of households being involved in policing. I don't understand why the police haven't done some public relations effort and just asked all the head of households to check their homes for weapons and drugs and to get rid of those things. I mean, those are sort of the campaigns that we need, is the involvement of all of us in managing crime. It is not just up to the police. But I do believe that we have to engage the police. We have to have a relationship with them, and they have to have a relationship with us. And this is how we're going to make policing better. Again, the George Floyd situation was really, it was really just a straw that broke the camel's back. When you look back all of the years, over all those years of incidents with the police, it was inevitable that there was going to be a situation like that happening. The only difference was that it was on video and it was for almost 9 minutes, and we all got to see it. Everyone got to see it all around the world. It was undeniable, and everyone knows that this has to stop, that we cannot have a situation like this where the police are simply out of control and have the discretion to do whatever they want to do if they just say that they feared for their life, that they could use whatever level of violence they want if they just say that. And they have been protected by the police unions, and it exploded in Minneapolis. And what we see and what we saw was the cumulative effect of all those years of unrestrained policing, and it's been harmful for everyone in the long run. Thank you for meeting with me today, and if you have any questions, I'll be available.
Dr. Garrett, thank you so much. Thank you for sharing your personal story and for your words of wisdom about the work that you have done. While we're waiting for questions to come into our chat box, and please folks do send them in, I would like to ask you to talk a little bit about how advocates, particularly mental health advocates, can further work with the police in order to things better for relations with communities at large and community members with mental health issues.
Well, Debbie, thank you for having me on today. This is an important topic. And yes, mental health advocates are very important and have an important role in policing in general. An organization like NAMI, the National Alliance on Mental Illness, have advocates. And advocates are important because the police really don't know how to identify mental illness. They don't know how to respond to mental illness once it is identified. And mental health advocates can offer the education and supports for the police to help them to respond better to persons with a mental illness. There should be mental health advocates in every police station and offering ongoing training to the police on how to deal with mental health and just emotionally charged people. This is part of the de-escalation training, is learning to address when people are so emotionally intense that their judgment is just kind of skewed, and they're likely to be highly reactive and result in that situation where the police say they are fearing for their life and they have to use their firearms. But mental health advocates are very important to policing. I think it should be an integrative part of police work.
Thank you, Dr. Garrett. I think you're absolutely, and when I was in Philadelphia, when Dr. Evans was commissioner, one of the things that a coalition did was we worked to bring CIT training into the city of Philadelphia, and it was greatly embraced. It was embraced by Commissioner Charles Ramsey at the time, who went on to be commissioner in DC. And in DC, in the previous administration, there was a dialogue and there was a roadmap that was being put in, led by Commissioner Ramsey, and I had the privilege of being part of some of those listening sessions as to how we could get people with lived experience to tell their stories, how we could work with the police officers. And I'm especially grateful today for you talking about the fact that the police officers are also dealing with their own set of mental health issues. So would you like to speak to how we can continue that dialogue, and then speak to how we can further engage police officers in addition to their own mental health issues?
Sure. Yeah, the police tend to think of themselves as the helper and as the person in control. And that's really dangerous thinking for mental health issues. When you think about the fact that on a daily basis, the police are encountering highly stressful situations that have an emotional impact on them. But if they are thinking that I'm okay and that it was nothing, and they go on to the next event, they are internalizing stress. And it shows by the emotional problems that police officers have, but it also shows by the fact that police tend to become highly reactive when something happens then. If they are already emotionally charged and then an event happens, they will be reactive to it. And when you have a reactive situation and a person has a firearm, there's danger for everyone in those situations. And so it's up to the leadership of the police department to integrate mental health into their training and into their services and practices. I think that they should not wait until an officer has symptoms or behavior problems to get them help, because you should assume that any person who is engaging in frequent, highly stressful situations and high risk, that they will have an emotional reaction to it, develop symptoms of at least depression and anxiety. And the result then is going to be overreactive behavior when an incident occurs. So it has to be integrated, and it has to have buy-in from the police leadership. And my experience has been that some of the leadership of the police department are sort of old school, and they think that, oh, you know, we're tougher than the general public. We can handle this. You know, that's not an issue for us. And I think that's communicated down through the ranks. And I think that officers are afraid to talk about emotional issues because they're afraid that they are going to be penalized in some way, or lose their jobs if they have an emotional issue or problem. When you see that a high percentage of them do have those issues, but only a small percentage of them come forward and admit it. So it's a systemic issue. It's a systemic issue.
Thank you, Dr. Garrett. We have a bunch of questions coming in, and one I'm going to acknowledge, but say that we're going to address it later, and that's whether CIT training is enough. And we will be diving deep into that in the panel that will be coming up a little bit later. But we have some other questions about how do you see psychological associations and psychological training as being part of training in police academies?
I think that it should be an important part of police training. In fact, psychologists participate in the selection of police officers. And what happens is that even though a psychologist may not recommend a candidate for police work, sometimes the police department hires them anyway. and they prefer people who demonstrate personality characteristics of uh, uh, aggression and having high control needs. And so I think that psychologists can help in terms of helping with the selection to rule out those people who may be impulsive or reactive or who have poor judgment. I think that on the front end that can help. But then after that, there needs to be ongoing evaluations of every officer. Every officer needs to have at least some sort of mental health checkup periodically, even if they don't have critical incidents because they are exposed to it vicariously. You know, they have friends who are police officers. They're a group that tends to more socialize with each other more so than the general public, and their friends are in the same boat. Their friends are not going to be able to help them with the emotional issues that they're having.
Thank you,
So it
Dr.
has to be
Garrett. We have
integrated.
one more question. Yep, we have one more, and we need you to do it in 1 minute again. Sorry for the short
Okay.
time here. But what do you think is going to have the biggest impact for racial justice for communities of color?
Well, you know, I think that the biggest impact is going to be, first of all, integrating the police department. I mean, from a diversity standpoint, I think that that would have the biggest impact. It's just plain diversity, because you'll find the leadership of police departments being predominantly white and being predominantly white people who don't live in that city. Most of the time, they live in the suburbs outside of the city, and they don't feel a connection, don't feel a community connection. And so I think that increasing the diversity, actively recruiting and hiring, not just men, but women as well, because women have a hard time getting into police departments. And women tend to do a better job of de-escalation and negotiation, in critical situations than men do. And the guys think more about force and power, and the women think more about discussion and negotiation. So I think the diversity aspect is probably going to be the most important. We need a lot more cultures on the police department.
Thank you so much, Dr. Garrett. Thank you again for being with us. It's my pleasure now to introduce our next speakers. At the risk of being teased by Paul, who's the director of Mental Health America. Yes, all roads do lead to Philadelphia, so it's really my pleasure to introduce a longtime friend of mine, Dr. Jennifer Wood, who's at Temple University. And Jennifer is a researcher in all aspects of mental health and criminal justice. And she's joined today by another colleague, Dr. Leah Pope from the Vera Institute for Justice. And I'm going to turn things over to them now. Please join us as we listen.
Greetings. My name is Jennifer Wood from the Department of Criminal Justice at Temple University. Thank you so much for welcoming me, along with my colleague, Dr. Leah Pope, to tell you a little bit about a new study that we're implementing. We share the same concern as all of you do here, that people affected by serious mental illnesses are disproportionately caught up in the criminal justice system. More than 1 million people affected by SMI are under some type of correctional supervision. And also every year, over 1 million people with SMI are arrested by the police. The existing research shows that between 6 to 10% of all encounters that police have with members of the public involve people affected by mental illnesses. And this figure is very likely very low because many police encounters involving interactions with vulnerable people, including people with SMI, are not captured in existing record-keeping systems. So how do we understand this extensive involvement of people with SMI in the justice system? Well, we know that people affected by SMI can be caught up in cycles of homelessness, involvement with medical institutions, including emergency departments at hospitals, and cycling through the criminal justice system. We know that the process of criminalization, which has been a decades-long process, has contributed to this phenomenon. And when we talk about criminalization, of course, we refer to the process by which people are arrested due to the behavioral manifestations of their illnesses. It's obviously important to keep people out of the criminal justice system. Staying in the system can exacerbate disadvantage. It can exacerbate one's health conditions. For example, it can delay treatment. If one has chronic illnesses such as diabetes, HIV, and untreated serious mental illness, those health conditions can worsen. It's commonly said that the biggest psychiatric institutions of the first half of the 20th century, that is state psychiatric hospitals, have been replaced by a new type of psychiatric institution, which are the jails in our biggest cities in America. Two of our biggest psychiatric institutions today are the Cook County Jail in Chicago and Rikers Island in New York. We want to emphasize here, and we know that this is central to the conversation, that justice involvements exacerbate disparities. And there's still much that we need to understand in terms of how these disparities are deepened and perpetuated through involvement in the justice system. What we don't know enough about is how perhaps a sequence of decision making across the criminal justice system can lead to a kind of cumulative disadvantage. And it's really important to understand that, particularly in relation to perpetuating racial disparities, but also in terms of perpetuating various forms of socioeconomic inequality as well. So where do we start to try to get a better and more granular understanding of how people affected by SMI get caught up in the criminal justice system? Well, one place to start is to look at misdemeanor arrests. And there's two reasons for this. One, if we look at general trends in arrests and general trends in how people come to be justice involved, we see that that involvement is due to charges that are usually misdemeanor, nonviolent charges. The Vera Institute of Justice recently produced a report that did an analysis of arrest trends in the United States. And it was very striking to see that a very, very small proportion of charges are for violent offenses. And many charges are for quality of life type behaviors and low level misdemeanant behaviors. This is in terms of the population in general, but also in terms of people affected by serious mental illnesses. There have been a few studies that have looked at the involvement of people with SMI in the justice system due to misdemeanant behavior, but we certainly know very little about the mechanisms and processes that lead to these police encounters in the first place and lead to people ending up in jail and sometimes cycling back into the jail system due to a focal misdemeanant behavior. Also, we should note that our colleague, Dr. Michael Compton, in a recent NIMH-funded study, discovered secondarily when he was looking at the arrest records of people affected by serious mental illness in a population of people who were involved in an NIMH intervention, NIMH-funded intervention, that those individuals were predominantly caught up in the justice system due to misdemeanor charges. So Michael wanted to know more, and therefore he brought a team of us together to better understand the phenomenon of misdemeanor charges being used among people affected by SMI. Our study team is led by Dr. Michael Compton at Columbia University. We also have Dr. Amy Watson, Dr. Leah Pope, and myself. We bring different disciplinary perspectives to the study, essentially psychiatry, social work, anthropology, and criminology. We're surrounded by a fabulous research team consisting of Adria Zern, Jason Tandabibiana, Aaron Stegoff Belfour, Amanda Warnock, and Neely Gesser. We have 4 main study objectives, each informing the other. The first step of the study is to identify 2 to 5 misdemeanor charges that appear to be driving the overrepresentation of people with SMI in the justice system. That is done through the use of administrative quantitative data. That part of the study has now been completed, and Dr. Pope will speak to what was found shortly. The second stage is to understand the use and processing of misdemeanor charges generally, but also in specific relation to those specific charges that we have identified in the quantitative data set. We should add that this process of understanding these case flows is being conducted in all 4 cities, Atlanta, Chicago, Philadelphia, and New York, through a systems mapping exercise that Dr. Pope will explain. The findings from that systems mapping piece will inform in-depth focus groups with police officers and other justice system actors, including prosecutors and judges. This piece is really meant to dig in deeper and understand the various formal and informal factors that shape decision-making across that sequence of criminal justice events, beginning with police decision-making. And then finally, we will examine what was learned through the systems mapping piece and the focus group pieces in all 4 sites and create an explanatory theory, trying to really at a higher level understand what is this phenomenon that we're seeing, what is happening here in terms of misdemeanor charges being used and applied, what's leading to this phenomenon, and are there particular points in decision making beginning with police, but also beginning with activities to call the police in the first place, where we may intervene and to try to keep people with SMI out of the justice system. And of course, that is the policy piece that is of central concern to us.
I'll take over from Jen here. My name is Leah Pope, and I'm a senior research fellow at the Vera Institute of Justice. I'm going to dig a little deeper into how we designed the study and some early findings. As Jen mentioned, the project has quantitative and qualitative components and involves 4 key activities: administrative data analysis, systems mapping, focus groups, and synthesis and dissemination. Given how little is known about the specific charges that people with serious mental illnesses receive, we wanted to start with understanding whether there were data sets that could tell us which charges might be overrepresented. We started with 2 data sets that we knew we had access to, the first from New York State, which is the data set I will describe in a minute, and the second from Dr. Compton's study in Georgia that included 240 people. Subsequently, we've been able to analyze additional data from other sources. For example, in New York City, the Department of Correction releases a daily data feed to an open data portal that provides data on people in custody. And from this, we were able to look at 120,000 admissions from August 2017 to April 2020. A little bit more about the New York State data set, since this really started to inform the charges we have ended up focusing on. We started with an arrest data set, all arrests for misdemeanors or felonies other than vehicular and traffic offenses between January 1st, 2010 and January 31st, 2013. This was an event-based analysis, so it included all arrests, including rearrests of the same individual. And we had over 2 million arrests in the sample. We were then able to match this data set against a data set of service recipients as determined by Medicaid billing records and state hospital admission and discharge records. This included any person who had been diagnosed with a serious mental illness in 1 or more treatment episodes in the year prior to their arrest. And matching these samples, you'll see that of the 2 million arrests, about 4.1% of those were among people with serious mental illness. We then ran several analyses based on the way arrest charges can be categorized. First, we classified charges as violent or nonviolent crimes, and we found that arrests involving people with serious mental illnesses were significantly less likely to be for a violent offense. Second, we categorized all of the charges as either misdemeanors or felonies. In New York State, there are 3 classes of misdemeanors and 5 classes of felonies. And we found that arrests involving people with serious mental illnesses were significantly more likely to be for Class A misdemeanors and Class B felonies. Notably, Class A misdemeanors account for the largest share of arrests among both groups, so 50% of arrests in people with and without SMI, but they also accounted for the largest disparity between the groups. Finally, we got more granularity by looking at uniform crime report codes and specific arrest charges. First, uniform crime report codes, or UCR codes. These are categories of arrest charges determined by the FBI. For example, there is a UCR code that is called larceny theft, and that in New York State includes 66 arrest charges. Here you'll see quite different categories were overrepresented in these groups. People with SMI versus those without SMI. However, the magnitude of excess arrests was also striking. So for people with serious mental illness, there were about 12,821 excess arrests among a group of only 91,000 arrestees, as opposed to around 12,000 excess arrests for over 2 million people without serious mental illness. Finally, we rank ordered the most common charges for each group. The top 5 charges were the same across both groups. So you'll see that petty larceny, assault in the 3rd degree, the top 5 are the same in slightly different orders. But if you look at the top 15, there are unique charges that appear for each group. For example, whereas charges related to driving under the influence of alcohol were more common among those charges involving people without serious mental illness, criminal trespass charges appeared among the most common involving individuals with serious mental illness. We used all of this data in combination with our conversations with stakeholders to eventually narrow down the charges of focus for our systems mapping exercises to criminal trespass, petty larceny, and assault. And importantly, we wanted to be able to focus on the 3 same charges across all 4 cities so that we could then compare the case flow in each of these cities. Since selecting these charges, we've been preparing for systems mapping in each city and just completed the systems mapping exercises in New York last week. The goal of this meeting in each city is to generate a visual depiction of how the system processes specific misdemeanors with details on case decision-making stages and case flows, information on the factors that shape decisions at each stage. And you'll see here a snapshot of the Manhattan systems map that we created last week. This proceeded in 3 stages in the actual meeting. In the first stage, we went through a criminal justice case flow for misdemeanor charges in general. We then went back and looked at decision-making points in the criminal justice case flow for mental health service activation. So in this case, we were looking at specific cases and instances where someone with a mental illness might be assessed, referred, diverted to treatment, etc. Finally, we went back and looked at the 3rd layer to examine how the case flow worked for the specific misdemeanor charges of interest. Once the systems map is completed in each city and revised as necessary, we plan to do stakeholder-specific focus groups with 1 group for district attorneys, police, public defenders, service providers, and people with lived experience. The goal here will be to get additional understanding about when and why these charges are used, as well as the formal and informal considerations at each decision-making point. We'll also consider other factors that may influence decision-making, such as race, substance use, poverty, and homelessness.
In terms of policy implications, which I know are crucially important to everybody on this call, we don't know what we're going to find yet. This is a discovery process where each phase sequentially informs the next phase of our study, but certainly our objective is to contribute and advance the debates around how to best keep people affected by SMI, not only out of contact in the justice system, but finding ways to really ensure that people affected by mental illness encounter police officers as little as possible. We know that police officers have a very tough job. They have very few tools at their disposal. They can arrest people, they can trans people to emergency psychiatric facilities, and then they have this sort of gray zone space where they do the best that they can informally to resolve encounters in ways that achieve the peace and minimize harm to the individual concerned and to any other individuals who may be involved in a situation. So part of the debate, and this is something that Vera Institute has argued as well, is that we need to provide officers with more tools in their toolbox. But there's a more fundamental question, of course, is what are those upstream conditions that lead to people encountering police in the first place? And of course, this is where inequality comes in, disadvantage, racial disparities, and the range of contextual factors and individual level factors that bring police to situations involving people in distress and in crisis. And obviously it is those upstream interventions that avoid that initial focal police contact in the first place that are really crucial. So I am sure that we will illuminate some insights around those upstream conditions that lead people into contact with police, and we're confident that police officers through the focus group process will illuminate those situations from their perspective. However, our systems mapping and focus group processes are really emphasized on understanding those sequence of decision-making processes that happen throughout that cascade of criminal justice actions. We may be able to identify particular areas of policy or law or standard operating procedures that may have an impactful outcome for people affected by SMI. Bail reform is one of those recent areas of reform that has really had an impact on how people travel through the system. And Dr. Pope could speak to that in more detail if that's an area that interests you. But we welcome your insight and really embrace your feedback as we move forward with this study, and particularly as we address issues of inequality and disparities in health and justice outcomes among people affected by SMI. Thank you.
Thank you so much, Dr. Wood. Thank you so much, Dr. Pope. It's a pleasure to meet you, Dr. Pope. And hi, Jen.
Hello. Hi, Debbie. Great to see you.
Thank you. We're really very honored to have you both here with us today. We know that the folks in our audience will be contacting you, but I'm going to open things up for question and answer and invite people to put those questions in the chat box now. But I'm going to kick off with asking a question about, is the study looking at when folks get rearrested and how that adds to the seriousness of charges, especially around parole violations?
Well, I think we can both offer perspective on that. I'll start with Leah, if I may, and then I can certainly build on her insights.
Sure, absolutely. So we're definitely looking at both people who are arrested for the first time as well as people who have been rearrested. And we know that many people with mental illnesses, as well as those without mental illnesses, cycle through the system multiple times. So we just did our systems mapping in Manhattan last week, and one of the things we talked about was just this, in terms of kind of asking people to think about system flow for people on their first time versus people who are coming through again and again. And I would say in Manhattan specifically, particularly with bail reform, there is an effort to lessen the consequences for people who are being rearrested. So it's really trying to stick with the charge at the present arrest as opposed to looking at the whole arrest history. But we know that consequences build up and the downstream effects, accumulate. So it's definitely something we're interested in. And particularly, I'll just add another point that in New York, for example, now most misdemeanors receive desk appearance tickets. So if someone is being arrested, they're just given a court date several out. And I think one of the things we're curious about is the extent to which people with serious mental illness may have more trouble appearing in court on that specified date as a result, and then what the collateral consequences of that will be.
I would just add, Debbie, that's an excellent question, and sadly, we don't know enough about it. There's the great work of the Camden Coalition of Healthcare Providers across the river in New Jersey, and they've done some amazing work linking police arrest data with hospital claims data in several hospitals, and have identified smaller subgroups of individuals who have extremely high rates of being arrested and traveling to EDs. And so there's this point at which there's just this vicious cycle of crossing systems multiple times. And we just don't know enough about how their needs continue to be sort of exacerbated as they keep traveling through. And so what we were just talking about with our study team is there a threshold at which, an individual's been arrested so many times that police may say we need to try something differently than keep arresting the same individual on the same charge. And so that's really what we hope to illuminate, especially in the focus group process.
Excellent. We have a question about asking you if you would crosswalk racial disparities and serious mental illness and how this fits in here, please.
I think this is an excellent question. It reminds me of Dr. Evans' point about syndemics and the ways in which mental illness can co-occur with homelessness, disadvantage, and how that overlays with racial disparities and structural issues, right, that deprive people of opportunities and create opportunities for more police encounters. So I think when we crosswalk racial disparities, we really have to understand that police decision making is influenced by so many different variables. Implicit bias and racism is an important consideration in their decision making, but I think there's a range of other factors involved in the situation and the social circumstances of the offense that we need to unpack. And so there's no simple answer to that. I think racial disparities crosswalk at every decision-making point in the system, and we really need to get underneath that in a better way.
Thank you. We have a couple of questions regarding larger policy, things like housing stabilization, Medicaid benefit, and being able to have interventions such as having Medicaid available the minute folks walk out, how these kinds of things will fit into this picture. Can you elaborate a little bit, please?
Yeah, so, I think this is something that we want to dig into in our focus groups with the different system stakeholders. We're well aware, and this has already been a reoccurring theme, that it's clearly not just mental illness that's at play here, as Jen just mentioned. There are many intersecting factors that put people at disadvantage. And that are, leading to this continuous cyclical justice involvement, and housing is, of course, a huge one. And so there's a huge overlap when we're talking about the populations. And I think that's something we're very attuned to asking about and thinking about kind of what sort of interventions are available for diversion or alternatives to incarceration, not only offer services, but also offer stable housing. In terms of the Medicaid benefits, also, perennial question, since most places cut off Medicaid benefits right away, and there's a whole process. Speaking from New York perspective, the city has gotten much better at kind of integrating the on-off switch into the jail process, but it's still a real outstanding question, and leads to all sorts of, I think, larger ethical questions about like how we pay for medical care and who's responsible, and is it the responsibility of the local community or the state or government.
Thank you. These are, as we can see, they come across all of the systems. And one of the things that we look at as advocates is legislation in place to deal with some of these things. One of the most important things that we are all working to advocate for is to get that Medicaid bit turned on and to expand Medicaid. We know that having services in place will prevent folks from getting arrested in the first place in a lot of instances. And we know that if they do end up in the criminal justice system, things will be in place for them when they get out. This has been a really fascinating conversation about your study. As I said earlier, I know you're going to be hearing from our folks. They're going to want to have some input, and I would like to invite you back at a future date to keep us apprised of the study and the types of things that you're finding out. So please accept our most sincere thanks for being with us today.
Thank you.
Thank you so much.
You are welcome. And folks who are joining us, I know we've had a lot of amazingly long information and lots of really in-depth policy stuff, and we have a lot more. So I'm going to invite you, it'll be about a 5-minute stretch break. I know everybody needs a little bit of a stretch break, and then we're going to come back with a panel where we're going to look at some of the terrific models that are happening that are seeking to address many of the issues that we've discussed that far. So I'll see you guys in 5. Hi, everybody. Welcome back. I hope you enjoyed our jazzy piano music. I know that I'm enjoying it, and I'm glad that you're all still with us. We're going to really get into some meeting stuff, meaty meeting stuff. That was hard to say. And we really welcome your participation. So be sure to send us those questions all along as we begin here with our panel. And just like we do with our legislators, we like to catch people doing good things. We like to catch them doing right things. And we've got a panel that's going to talk to you today about some of the amazing things they're doing in their part of the country and across the nation. So today's panel, Bonnie Cook, and we are so happy that not only is Bonnie the executive director of our MHA of Dallas, she is also a MHA national board member. And we have Ashley Wilkerson, who is Wilksen, excuse me, Ashley Wilksen, who is from our wonderful MHA in Nebraska, which is one of our peer affiliates. And we have Paul Gladys from Recovery Innovations from RI International. And what we're going to do today with our panel is each of the panelists are going to have 10 minutes to tell us a tiny bit about them, about the programs that they're talking about. And the order in which we'll go in today will be Bonnie will be first, followed by Ashley, and then Paul. So, Bonnie?
Okay, can you hear me all right? Good.
We're all good.
Okay, great. Okay, hi, I'm Bonnie. I am the Executive Director of Mental Health America of Greater Dallas. Thank you so much for having me today, and hello to my staff that's on the call and to the other Texas affiliates that are on the call. So glad to see all of you. So I'm going to talk just a little bit about the Right Care team that is here in Dallas, Texas. The Right Care team, and I'm going to say it's RIGHT. My Southern gets in the way, so I wanted to make sure I said that correctly. It is a rapid response team, and it's a mental health emergency place that, and I'm going to move this phone that's going off, of course, right now. It's located in South Central Dallas, and for those of you that don't know Dallas, Dallas is a very segregated city, and so south of 30 tends to be an area that is short on mental health treatment. In fact, there was a recent study that came out that said there are only 2 providers of mental health services in South Dallas. So what Dallas did was they did a 3-year project, a pilot project, and I'm saying Dallas. I'm not saying the city of Dallas. I'm just saying Dallas. And this was a private funded grant from the Caruth Foundation and Community Foundations of Texas. And the goal of the Right Care team was to divert mental health patients from area emergency room departments. So it was the first of its kind of program here in Texas. And then there's a specially trained paramedic, a Dallas fire rescue person, a social worker, and a police officer. So what they did was they would go, you would call the Right Care team. So you would call 911, and after you called 911, you would get someone from the Right Care team. One of the limits of the program was that though it only served South Dallas. So one of the issues that we've had as a mental health organization is when someone calls and wants us to get them directed, we have to make sure that they live in that particular area. And we're finding out that there's a need throughout Dallas for these services. So last year, the Right Care team responded to more than 2,500 calls. And then this is a partnership with Parkland Hospital. One of the results was Parkland saw a 10% decrease in emergency room visits from that particular zip code. And after you would do the Right Care team and they would come, they also would do a follow-up call. So the follow-up call, they did over 800 follow-up calls. The team averages about 4 to 6 emergency cases per shift.
So it is a very promising program that we have here in Dallas. We're lucky to have found out just this week that the city of Dallas is now considering funding that program. One of the challenges also of this program is you've got these different coordinating groups, and it seems to be difficult to determine who is the one that is in charge. So at MHA of Greater Dallas, we are working really hard to work with these organizations and work in the community to bring everybody to the table. So like with other affiliates across the country and here in Texas, part of our role is to be that bridge. And so we are working hard to be a bridge for the Right Care team and for the people of Dallas. The city council met recently to approve our budget. And like I said, there was money put in the budget for funding the Right Care team. So that is a plus for us. And we are trying to work hard with our police department and our officials to see what we can do to incorporate mental health in with the police. So that's very basic what we are in 10 minutes.
Thank you so much, Bonnie. Ashley, please tell us about the fabulous programs that are happening in Nebraska. Oops, we're not hearing Ashley.
There we go. Can you hear me now?
Technical. Yep.
Okay, thank you so much. So yeah, thank you for having me. That was awesome to hear about Dallas already. I'm excited to hear about the other programs. So here in Nebraska, we have the REAL program, and it's REAL, which stands for Respond, Empower, Advocate, and Listen. So what we are here, as you mentioned, we are a strictly peer-run organization, which means all the way from the board of directors on down, we are all people with lived experience with mental health issues, addiction, trauma, previous incarceration. So yeah, we relate to people on that level. And so the REAL program came into existence right around, it was 2011. And, you know, it was very difficult at first getting in with the Lincoln Police Department, and not in a really negative way. It's just trying to introduce something different, right? But they, at the time, were looking at their EPC rates, emergency protective custody, and pretty much all of their mental health investigations were ending in EPCs because they didn't know what else to do with people and didn't have any other services to offer them. So what would happen, and what our process is when an officer came into contact with somebody that was obviously struggling with mental health issues, they can send an email, and typically within 24 hours, a peer contacts that individual. And what we have found since 2011 is that it is difficult to reach people. A lot of times people are couch surfing. A lot of times they might be homeless. So the individuals that we are able to connect with, which is about 62% of those referred, we have 85% of those individuals accepting services, which is awesome. And that's anything from, helping with, assistance with their utility bill, or dealing with domestic violence situations, or it's expanded now to a lot more than just mental health calls for service. We've gotten referrals for all sorts of different situations. So in 2019, we collected some data, and actually the police department was the one who collected it for us, and ran the numbers. And what they found was that it wasn't an immediate, we weren't seeing the results immediately. what they found was after about 24 to 36 months, they were then seeing the decline in calls for service for mental health investigations for one particular person, or for people who have been referred. And you know, at first we were like, oh, that doesn't necessarily seem like a really big benefit. But you know, we started thinking about all of the individuals that are referred. They didn't get in their situations or just start dealing with these mental health issues in these ways. It took a while to get there. So now it takes a little bit longer in order for them to maybe learn a new way of dealing with things, to get the medication that they might need, to get other resources and get connected, establish a support system. But so we found that really interesting. And we're excited to be, we're still collecting more data so we can have some more statistics. But yeah, we have a total of, I think it was 90% of the officers have referred to the REAL program. And there has been a significant decrease in the amount of EPCs. I think since 2000, let's see here. Well, just in 2019 alone, there was only 340 out of the almost 3,000 mental health investigations, which is due to not only the REAL program, but the other community partners as well that are working with the Lincoln Police Department to connect people to appropriate services. So I think that's all, but I'm excited to continue talking about that and hear about other programs.
Great. Thank you so much, Ashley. We're going to turn things over to Paul. And a reminder to our participants to please, anytime, start typing in your questions. Paul?
Yeah, please don't be shy. We are excited to be on a panel and we want to answer questions. And I will say, Debbie, this has been a fantastic day. The dialogue has been incredible, the discussion. And look, I don't know that there's been a better time to advance policy around mental health and substance use challenges than today. And with that in mind, maybe before I get into specific programs, just a brief bit about RI International is we certainly are strong believers in the power of peers in our workforce. So we have almost 1,300 employees as we're contracted for services in 9 states. Over half of those 1,300 individuals are peers with their own lived experience with mental health substance use challenges. And they inform, guide everything we do. They're in every level of our organization. And I think it's an essential part of our being. And so this past fall, I actually, we got outreach from SAMHSA, and they asked us to partner with the National Association of State Mental Health Program Directors, NRI, and others to develop the national guidelines on behavioral health crisis care. And I'm not sure if any of you've seen that yet, but it was published in February of 2020. And I think it's an important step, because what it said is it's not okay for those with mental health and substance use challenges to have a different and really a substandard level of care. And so
Whoops, we've got Paul frozen there. I'm assuming you're going to come back in a second or two, Paul, because I can't wait to hear about the national standards. One of the things that Mental Health America is really pleased to talk about while we wait for Paul to get back online is that we have a partnership with RI and with other peer organizations on creating national standards, as Karen talked about earlier, for credentialing, so that there is, no matter what state you are credentialed and trained in as a peer specialist, you have that level of competence that can be counted on all across the country. And RI is one of our partners in developing that and in working with that. And we are also partners in working on getting that into national legislation. So we are working on we are working to have a definition of peer specialist in federal law. And we know that once we have that, that is really going to open up as well. So that is another important part of our partnerships. Again, while we're waiting for Paul to come back, Ashley, I know the programs in Nebraska. They're fabulous. And we have featured them a number of times. In fact, we had Officer Luke come and along with Casey and speak at the National Press Club a couple of years back and talk about that phenomenal work. Can you talk about some of the other programs that are happening as well, such as your programs that help people when they're coming out of criminal justice system and helping them get back on their feet and into the community?
Yeah, absolutely. So we have a couple different programs specifically for people reentering after getting out of state correctional facilities. So we have the supported employment program. Obviously, it helps people obtain and maintain employment. And it's not a cookie cutter place people in jobs. We want to actually find out what people's skills, their strengths, what they are really wanting to do, and help make those connections and be support along the way. And with that program, the one really awesome thing is that they decide when they end services. So it's not, 90 days you hold a job and then, your employment specialist goes away. We can follow people's journeys for a long time. We also have an outreach worker, which helps with basic needs, right? When individuals are getting out, a lot of times people don't have a lot of clothing. Sometimes they don't have food. They don't have that kind of stuff. So people are able to get them connected to those resources around town. And also, she has done an amazing job at building relationships with different landlords that will help give people a second chance. A lot of times people coming out of correctional facilities don't have a great credit and a great rental history at all. So those connections are really important. And then we have Hanu Home, which is our transitional living, and individuals can stay. And then the length of stay is really depending on the person's situation. We're very fortunate that we're able to be really individualized. A lot of people, some of them, they just need somewhere to stay for, a month or so while they get on their feet, and they're able to transition pretty smoothly. Other people need a lot more time, depending on how long they did in the correctional facility, how much trauma they're endured before then, or even within the facility. That it really, we've had people stay a couple weeks and move on and do great. We've also had people stay, I think the longest one was maybe 8-9 months, because they were in for a very long time, and it took that long. And so, like I said, we're fortunate to be able to really individualize those services and kind of provide that wraparound support as well.
Thank you, Ashley. I was going to ask about the other programs a little later, and we have Paul back. Paul, you have your full 10 minutes. Please go.
Oops. So I don't know what happened and apologize for that, but I'll just jump in with what services look like in Arizona. And I will suggest that if you look at the SAMHSA national guidelines, there's a toolkit that says how you can actually fund these services, how you get reimbursement. Medicaid expansion does play a big role. And in fact, it would lower overall health cares in communities, meaning the state budget, the county budget that is now strained would actually be eased a bit if you advanced and added crisis care into your mix. And so there's a good roadmap for that. So in Arizona, what it looks like is that we have a crisis line that anyone can call. And we know that 988 is on the horizon for us, which is fantastic news. And as 988 takes those calls, we heard earlier today, 90% of crisis calls are resolved by phone. That's why you don't want 911, because that's not a focused intervention that could resolve 90% of calls by phone. But they do that very successfully. The National Suicide Prevention Lifeline affiliates are really well prepared, and they're developing that network even more to answer these calls as volume grows in the next couple of years. The next thing Arizona does is they connect you to mobile crisis services. So if that individual that's a caller actually needs additional support, which is 10% of the time, they send out a mobile crisis team. And they have enough of those that they've created real-time access to care. And so you would expect in a metropolitan area anyway, in less than an hour, a team is out there. And usually this is a team of 2 individuals, a licensed professional and often a peer, that goes out and connects with the individual, engages them, and provides support. 30% of those individuals need additional support beyond that, meaning 70% have resolved to stay in the community. For those that need more, we have crisis receiving centers. And our crisis receiving centers say yes every single time an individual comes in. And data in our Peoria, Arizona, Maricopa facility is that we have 400 law enforcement drop-offs every month that come to that facility. And we accept those referrals in an average of 2 minutes, meaning law enforcement shows up. And in our community, we now for 4 straight years have had over 22,000 law enforcement handoffs to mobile teams or crisis facilities. So when I say crisis facilities and I say mobile teams, I'm really saying those that are designed to be emergent responses, much like an ambulance would or an emergency department. You don't have an option of saying no. You go out there and you engage the individual. So therefore, we get true justice system diversion, because law enforcement isn't wondering, well, if I go over there, do I need to convince this agency to take a referral? We take them. The answer is always yes. In fact, in our training, it's with law enforcement, and we say, thank you, can I have another? And we're fortunate enough to have a significant number of CIT trained law enforcement officers that are out there, and they bring them to us. So again, 400 times a month in this one 36-chair facility, we get drop-offs from police. We take them, we bring the individual in, we engage them with a peer first. There's a peer with them last. They're seeing medical professionals. They are getting the support they need, and there is no delay in accessing care. And what we've seen, and Arizona Medicaid has helped us model this out, is it's over a $2 to 1 return on investment for what they're paying for crisis care. And they benefit from the federal match of covering those services. So in fact, it is far cheaper on the state of Arizona and Maricopa County to have real-time access to specific mental health and substance use services than to not have it. Because the other answer is individuals are getting engaged in the justice system or they're going to emergency departments. And those are costly interventions. They don't resolve the issue. And so we really have created what I believe is a system that's being modeled around the country, which says offer real-time access. It's not only the right thing for our communities, but it's also one that's modeled after what we already see. 988 will be similar to 911. It's a number you can call to talk to someone. We know that much like 911 could dispatch an ambulance for care, which they will do for physical health emergencies, or it could be fire. We also know that when you call 911, which is what happens for emergencies now, that's the number we really know. If it's a mental health or substance use crisis, police are being sent. Police are trained on public safety. They may have had crisis intervention team training, but in fact, they are not focused mental health professionals delivering that care. So it's not okay. And I think as a policy, we need to say it's not okay. And as 988 starts to stand up in the next year or two, we have to push forward and say we need mobile response so that we can follow up with those individuals that have greater needs. And we need facilities that are going to say yes, much like an emergency department will when that's needed. And again, in Arizona and in Maricopa County alone, that's happening over 22,000 times each and every year. And we get fantastic outcomes, not only lower cost, but of course, people are having better experience than being incarcerated, better experience than waiting in emergency departments for hours or days at a time. The research that we had put into this suggests that 45 years of psychiatric boarding in emergency departments is avoided by having real-time connection to care by providers that say yes every single time. So I do encourage you to think about how that might look in your communities. We know it works in many around the country, but so many more simply don't have it at this point. And so if your community does not have a place in which someone can walk in anytime, family can bring them in, law enforcement can bring them in, then I think we're falling short. Imagine what our physical health world would be like if we didn't have emergency departments to go to when we really were in a pinch or someone really needed care now. It wouldn't be okay, and it's certainly not okay for mental health and substance use needs.
Thank you, Paul. You answered one of the questions that's already come in about how we move beyond just CIT and de-escalation training, and that was a great answer to that. I want to go back a little bit to a question that came in at the end of our last panel. I want to address this one to Bonnie. The question was about training folks in the field at every step of the criminal justice involvement systems that people with mental health conditions come in. How does educating them on ACEs, adverse childhood experiences, fit into this paradigm?
I think it's very important that we talk about ACEs with our MHA philosophy of before stage 4. I do think that our criminal justice system doesn't operate from a before stage 4 philosophy, and they don't operate from an ACEs philosophy. So I think part of this is a paradigm shift for police officers in the criminal justice system to go upstream and to go back further and to begin looking at these childhood experiences and the trauma that children face in their lives. And sometimes the trauma they face at the hands of the criminal justice system. So I think part of it is for us as mental health advocates to bring that to the forefront and to also to to recognize that police officers aren't trained the same way that we all are trained. And I think part of that education, and for us to move one step further beyond that CIT training, is to use adverse childhood experiences, to use our own personal stories and our own situations of before stage 4, and help them to understand that, pay me now, pay me later. So if we start dealing with this beforehand, I think that's a really great way for us to start that conversation, to start that discussion of programs beyond CIT. And I think, too, for us is sometimes we have to meet law enforcement where they are. I've had experiences in our office with law enforcement coming to our office with someone that's been mentally ill and did not handle it in a manner that I thought was appropriate, and was quite angry with those police officers for a month, 2 months. And finally, when I reached back out and did talk to them about where they're coming from and that their situation and their end result is different from what our end result is. So the more I think we can educate them on other ways, I think the better off we're all going to be.
Thank you, Bonnie. One of the things that we haven't addressed in as great detail, so this is for any of the panel members that would like to answer this, is what are the ways that in these models of addressing folks who come into the system, what's the sensitivity towards LBGT folks, and how can we improve that?
So I can jump in. It's certainly very important, and interestingly, as we think of, there's so many different elements to culture, but one of the biggest of those is going to be gender identification on top of LGBTQ communities. And I think we have specific training around those things. And in fact, we have peers that often align with those communities. And what we've tried to do the best we can is hire staff members that represent the communities we serve. And I think that goes a long way to help with engaging. There are a lot of different versions of peers when you start thinking through that, and someone that can really connect and engage someone. One of the other things we think about in communities like Fayetteville, North Carolina, and Jacksonville, North Carolina, where we operate facilities, is we're right next to military bases, and there's a culture that goes with that as well that's really important. So I think you have to be remarkably sensitive, and I think the first step for any provider is do your best to not only educate your teams, but try to have team members that represent those who serve.
Thank you. That's a really important point, Paul. And again, I'll open this to any of the panel members. We heard earlier, and Dr. Garrett especially focused on this about the militaristic, if you will, training that police often have, and how do we address that, and how do we get them to work more with the social services that we have in our communities and that really are what people need in many instances.
I'm going to jump back. Go ahead, Ashley.
Oops.
Go ahead.
Sorry. So one of the things that we're doing is we are part of the beta training here in Nebraska, which is pretty much a threat assessment training. And originally it started about 10 years ago, and it was really trying to identify the difference between criminals and people that are struggling with mental health and addiction, and how, yes, sometimes those things can overlap, but really focus on how to address those different populations. And this is for officers. It happens every year. We can train up to about 65 officers. And part of doing that is we have a panel of peers that goes in front of the officers, and they talk about their own experience, whether positive or negative, and talk about their own lived experiences with the police officers and what things made things worse and what things were very helpful in those moments. And also reminding them that they're seeing people on their worst days, right? And like here's what they look like normally, and when they're doing well, and when they're taking care of themselves and their needs, and getting those needs met, and really being able to see people more than just on their worst day. So beta training has been really, really helpful. We also are doing training with the new recruits, with dispatch, with the dispatchers, with the LFR, with fire and rescue, and really trying to get that message out there that dealing and working with people with mental health issues, you're going to have so much more, I guess, better results if you come at this with a empathetic mind and a more educated stance than coming at it from the traditional militaristic style that you're talking about. And it took a long time. When we first got the REAL program going, we literally bribed these officers. We made things like whoever has the most referrals this month gets a gift card to a restaurant or something like that. And it worked, though. And then they started seeing the benefits, and it built from there. And we no longer have to bribe them in order to get them to refer people to services. But I think they just have started noticing more and more when they utilize the skills that we're trying to teach them and we're talking about, they have better outcomes. But it does. I feel like it takes a long time. It's a whole culture that is used to one certain style and way of dealing with people. And we're trying to kind of flip that upside down, and it's difficult, I think, to grasp.
Thank you, Ashley. Bonnie, you wanted to jump in here?
She covered a lot of what I wanted to say, but I think, here in Dallas, this is an opportune time, but in Dallas, we do not have a mental health liaison in the police department. So I think part of it for all of us as advocates is to start, to find that one police officer, that is willing to partner with you. I think one of the challenges we face is police departments are a good old person's type culture, and you need to have someone that is one of theirs to go in and to start that message. And I think that goes a long way with trying to deal with the that type culture. The one instance that I referred to earlier, it was one gentleman that needed assistance. They ended up having 4 police officers come into our building. The gentleman was in one office that was a 8x8 office. And I said he needed assistance. And the police officer said, okay, so do you want us to take over?
And I said, yes, I would like you to take over. The minute when I said, yes, I would like you to take over, their mannerisms changed. And then that became an instance of this person was a criminal as opposed to someone that needed mental health care. And the testosterone that just all of a sudden, from the room. And so I think part of it, as we started thinking about it in Dallas, what we needed to do was you need someone from the inside to be your partner and to find that one person to start addressing some of these issues, because they are coming at it from a different perspective than we are.
Thank you, Bonnie. Paul, did you want to jump in here on this question?
Well, all I would say add to it is, look, the one thing we're trying to do, this is a policy group that we're thinking about. There is a faulty policy when law enforcement is involved more than any other mental health crisis response is. And that's the default, right? 911 never sends a mobile team that I'm aware of. They don't even have the ability to do it. And far too often, 911 doesn't transfer to your local crisis line. So police are coming. And so we're trying to address the way police do their work, which is challenging because they are first charged with public safety, and they are going to stabilize the situation and take care of this the way they need to for safety first. And it doesn't mean they aren't well-intentioned and trying to do the right thing, but I think this is a policy issue for us. We have to get people connected to care. Police don't show up for every heart attack or every other medical emergency. They're not there for that. They're not there for fire. They're there because it's a mental health or substance use issue, when in fact we have mental health responses that could be available and should be.
A very good
Thank
point.
you so much. Yeah, it really is. One of the things that I saw work very well when I was in Philadelphia when we brought crisis intervention team training was that the operator, when we knew it was a mental health call, it was switched to the dispatcher, who was a social worker, and she was trained in this, and she knew how to talk to folks on the phone while they sent out the mobile crisis team, which also had peers in it. Now, that said, as it sounds perfect, there's never enough of it. And so we couldn't always make that happen. That kind of leads to a couple of the other questions that have come in, and I'm going to combine them and give you all a shot at this. But that's about mobile crisis. And who do you think should be in mobile crisis? And if you had all the money that you could wish for, how would you expand your programs, and what would be the most important part of that?
For us in Dallas, like I said, right now the program is south of Dallas, with this imaginary line, and we all know mental health is not geographically isolated. And while those services are limited south of Dallas, the crisis of mental health is not limited within Dallas. So if we had all the money in the world, I would like to see the Right Care team expanded to cover all of Dallas. Heck, I'd like to see it cover all of Texas for that matter. And then, I'd like to see a concerted effort that we do talk about preventative measures and making it to where the police officers are not the mental health providers here in Dallas.
Yeah, so I would add this. I think mobile crisis should be everywhere, and I actually think the only thing that has to be done is create the better expectation. So 988 is going to push us that direction. When you have calls and you can't resolve them, is the other plan to transfer them back to 911 to send police? That doesn't make any sense to me and gets away from what we're trying to do. So I think it's a logical kind of progression to say mobile response is going to be an expectation, much like ambulance availability. And in fact, part of why those things are available is because they're more affordable than getting people only to emergency departments or sitting in hospitals for extended lengths of time, which is what happens now. Or for mental health and substance use crisis, we're going to incarcerate them for extended periods of time and unfortunately not get care, and this cycle repeats itself. So I actually, again, I'm going to lean towards those SAMHSA national guidelines for behavioral health crisis care, but it actually talks about how to fund it. And the truth is, by setting the right reimbursement rates, and for those that are in Medicaid expansion states, Medicaid often drives this, and the federal match makes it pretty reasonable to do this work. It's just less expensive, and it's far better care. And if you just think the alternative is someone's getting dropped off in an emergency department, and then we figure it out, emergency departments average over $1,000. Mobile teams don't need a fraction of that to do the work in the community.
Are peers part of the mobile crisis in the communities that you serve?
What's that, peers? Yes. So,
Peers,
and actually,
yes.
again, if I lean back towards those national guidelines, for us, we do operate mobile crisis. Ours is a co-responder model, which isn't what I'd consider ideal with law enforcement, but ours are staffed with peers. And the national guidelines suggest that you should have a clinician paired with a peer for every mobile response. You can't send one person out, right? There are safety issues. And in fact, peers are designed to uniquely engage individuals in environments where others might not be successful. They've been there. And so absolutely right that in the national guidelines, it says peers should be a part of each mobile team, and they should be a part of every level of crisis care.
Thank you. Ashley, tell us about the mobile crisis, if any, in your area, and also what it is that you see as the next step in the evolution if money were not the object in the programs that you have in Nebraska.
Right now, we do not have any type of mobile crisis team at all. That would be amazing to be able to implement something like that here. You know, we do have with the REAL program, we actually, due to increase in calls for service, increase in utilization of our respite house, we actually got a COVID grant, a CARES grant, that is assisting us in the extra staff that we're going to need to deal with some of these issues coming in. And what we are going to do now is almost like you were talking about, Paul. We created a 2359 or 2359. Sorry, and the police department can drop people off and just come in, and when they're struggling and they just need someone to talk to, they can bring them to us. And we have a living room type setup where they can meet with a peer 24/7. And that actually is going to start, I believe, next week. So we are super excited about that. We, with the CARES grant, I believe it was like a 6-month, maybe 5-month thing. But I can guarantee you that this is going to open some doors, and I think we'll have some more opportunities that are going to fall into our lap to be able to expand that beyond 6 months. We've talked a lot about being able to go on the calls with officers, being we don't have any crisis mobile response teams. We don't have we at MHA here are not Medicaid reimbursable. So we do have those kinds of challenges, and we don't have clinicians on staff. So our alternative would be looking at actually going on calls with these officers and being able to maybe bridge those gaps immediately, rather than having to wait that 24 hours to make that connection with that person. That would be great if we could work towards that.
And Ashley, you touched on one other important thing. You said not Medicaid reimbursable. What I would encourage, crisis coding is actually pretty simple, right? Mobile response teams usually use H2011 when they can get reimbursed. Crisis facilities do S9484 for the hourly, S9485 for per diem. It's as simple as those. If those became, in a policy decision, essential services, therefore, they are required to be reimbursed by Medicaid, Medicare, and then a push for parity that gets commercial payers to do. We have to do it on grant funding disappears. Again, you don't have to do primary care, radiology, cardiology by grant funding only. It's healthcare.
Thank you, Paul. That was such an important point that you made, and I hope everybody was taking notes about those codes. We have found through our MHAs across the country that once they start employing the Medicaid codes, it's not as scary as they thought it was, and the reporting requirements aren't quite as scary as they thought they would be either. But you're right, we need to, because of the way healthcare is set up in this country, we need to be able to get it into all of the systems. That's why we're working to get peers and peer language into federal legislation. We are working right now to have peers covered. We're hoping, we're crossing our fingers, very soon we will have a piece of legislation introduced in Congress that will allow peers to be paid for in Medicare under collaborative care codes. So there's lots of different ways we can approach this, as well as having that uniform training across the country. I'm going to ask Paul in 1 minute to please tell us a little bit more about the SAMHSA guidelines for folks who may not be as familiar with them. And I also want to invite more questions to come into the chat box.
Yeah, so the national guidelines were published in February, and roughly what they do, it's 80 pages, but includes some case examples, including those from Arizona that I discussed. But it describes 3 core services. You have to have a crisis call center hub that answers all calls. You have to have mobile team responses that go to wherever the person is in need. And you have crisis receiving centers. It does discuss, there are a multitude of other services that are important, but those 3 core elements align roughly with 911, ambulance, and emergency department as analogies that we think parity should make them broadly available to all. And the guidelines themselves talk about an expectation peers be involved. It's trauma-informed care. It cites specific standards, and it talks about how you can fund these services and what the coding looks like. So it's really a fantastic guideline that in 80 pages, you get multiple examples. It walks you through how to bring this to life in your community. And to me, it sets a standard that's important for us to push forward, because now as much as ever, we need immediate access. It's just not okay the way we've operated for far too long.
Indeed. We've had a question that came in a little bit earlier, and please, all of you, to give a piece of this. But how do you help the folks who work in your programs deal with perhaps the secondary trauma that they may be experiencing when they help people in their communities?
Yeah, me first. I can just say this is hard work, right? This is hard work. And when you think of, I said the Peoria facility, 400 people a month on average come in the back of a police car. You're engaging people that for many of them, it's their worst day. We try to describe it as their biggest day. And in fact, in our first day of orienting our team members, we talk about the biggest day for someone. And it could be the 15th intake of the day for you, but for them, it's the first time they've been in the back of a police car, the first time they've experienced these symptoms. And how you respond makes all the difference. And I think our peers really support each other, and our team, since there's, again, over half of our workforce have lived experience, I think they've come to this unique place where they're crisis providers for each other as well. So although we offer support more formally that's available, the truth is the teams take care of each other much like a family, and it's a remarkable thing to see. And they celebrate each of the successes, because that person that came in otherwise was going to jail, or they were going to wait hours or days for care. Not today is the answer from them, and they really do lift themselves up in a way that I would fall short every time I tried.
I would definitely agree with that. It's become MHA is my family, absolutely, and we definitely carry each other through some of these difficult situations that come up. One of the things we do have every couple of years, we have a vicarious trauma training or a workshop that looks at acknowledging that vicarious trauma that comes in, and then figuring out those ways to deal with it. We talk a lot consistently about burnout and about, taking care of our own mental health issues. For us, I can speak for almost everybody, I think, in our organization, helping others helps me. And it oftentimes is a good reminder of where I used to be, and where I am now, and how grateful I am for the opportunities that I have now. So, you know, it is really difficult sometimes. We hold weekly staff meetings where half of that is just dedicated to debrief. You know, how did things go this week? Is there situations that you're hanging on to or that you need to talk about? And being really, really directly involved with our peer support staff that are doing the direct service work, and staying connected and engaged with them, and really just, you know, being there as a support for them through some of those difficult situations as well.
I think for us in Dallas, we are a small staff, and I think we need to all be able to recognize how each of us deal with our stress, and that their way of handling stress is different than mine. And I think trying to be patient as we deal with these issues, and try and have a little bit more grace. If you ever come to our office, we do have the what we call chicken, and we have this disgusting pink chicken that sounds like a baby crying. And if you squeeze the bark, bark chicken, that means you've done something well. So you'll get an email from me that says chicken, or someone knows they've done something well. And Megan's on the call, and Megan will send me a thing that says chicken. And so little things like that that you can do with your staff and with your colleagues to lighten up the day is something that that we all enjoy. And like I said, when we were back in the office and you hear that chicken thing going off, you knew somebody did something well. So I think that's something that we all need to kind of think outside the box and ways to support each other.
Thank you, Bonnie. That's such a wonderful thing to keep in mind, is that it's the theme of the day. We want to not only talk about what's wrong, identify the problems, look at them in the face, but we want to catch people doing something right. And panel, you've been marvelous, and the work that you do in the community is amazing. And please know that all the advocates who are here today and across our MHAs and our partner organizations are really going to take the wonderful things they've learned from you all today and try to put it into action. So I want to thank you for being with us. I want to thank our audience for being with us today. We know it's a long day. We know that this is a new way of doing things, our virtual way of doing things. We thank you so much for bearing with us with a couple of little glitches that we've had. We'll try to work them out for the next time. In fact, speaking of the next time, our next Regional Policy Council meeting, where we'll be expanding again on in-depth conversations, will be December the 1st. And that would have been in person with the Council of State Governments, but because of COVID, again, we will be virtual, and we will be thanking another crop of legislative champions. And speaking of thanks, I want to once again thank our MHA team for being with us, for doing the front end, for doing the back end. I want to thank all of our amazing speakers for sharing their knowledge. We will have more information and the slides available to you, and we'll be sending out a survey to ask you how we did and tell us how we can do better. We truly appreciate your feedback. I believe this session is, all of it, the whole day is being recorded so that you can step in and listen again to the presentations that you've heard today. So please accept my most sincere thanks, and we look forward to you joining us at our next Regional Policy Council meeting.